joining Shield Connect, a knowledge sharing platform of Shield Healthcare. So I, Dr. Suman, Regional Medical Advisor from Shield Healthcare, and it's my honor and privilege to welcome all of you in this very wonderful series, Trending Ask series, which is organized by AGOG, Academy of Global Obstetrics and Gynecology, on our Shield Connect platform. So in this task series, we'll be covering the topic from A to Z topics, and today the episode end, we'll cover the topics NCDs and case discussion. So before starting the session, let me show the short introductory video of AGOG. And now let us start with the Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So now it's my honor and privilege to introduce the coordinators of today's program, Dr. Kanchana Prasad Madam and Dr. Pradnya Chilbre Madam. Dr. Kanchana Prasad Madam did her MS, FICOG, FIOG, FMAS, Favorite Reproductive Medicine, Diploma IRT from Germany, and Madam is the Professor, TMMC and Arts in Moradabad. And Dr. Pradnya Madam completed her MS, FICOG, FCPS, DGO, and IBCLC. She is the Associate Professor, Department of Obstetrics and Gynecology, LTMMC, and GH. So with this short introduction, I would like to hand over the session to the coordinators, Kanchana, for further proceedings. Thank you very much.
Thank you so much. And now I would like to introduce the convener for today's program. It's my privilege to introduce her. She is none other than Dr. Komal Chavan ma'am. And as we all know her, she is a medical director, Chavan Maternity and Nursing Home, and senior consultant, DNB teacher and unit chief, VN Desai Hospital, Mumbai. She is ex-honorary professor, Dr. R.N. Cooper Hospital and HBT Medical College, and she has been chairperson for the FOXI Medical Disorder in Pregnancy Committee during 2019 to 22, and she has done commendable work during her tenure. And she is currently Zonal Coordinator for FOXI, Core Committee, VAD Cell FOXI, Chairperson amongst Family Welfare and MTP Committee, Member Managing Council, Mumbai OBGYN Society, Joint Secretary ISOPA Mumbai Chapter, Scientific Secretary AFG, and she is National Expert for FOXI UNICEF Lecture Project and National Trainer for FOXI Dhira and RSC Project. And she has been convener for FOXI Guinness World Records 2021, Break Free from Anemia. And she is recipient of various prestigious awards, including the FOXI Dr. Meru Dharan Sotia Best Committee Prize during 2021, and MOX Dr. Pramila Bhatia Scientist Award during 2022. She is on editorial board of Journal of Global Obstetrics and Gynecology, peer reviewer of Suffolk Journal. She has many publications in international and national journals and contributed many chapters to FOXI Focus, newsletters, and textbooks. I welcome you, ma'am. And now I would like to introduce the co-convener for today's program, Dr. Niranjan Chavan, sir. And we all know him. Sir is currently the Joint Secretary, currently Joint Treasurer of FOXI, and he is a Professor and Unit Chief at LTMC Sion Hospital. And sir has been President MOGS during 2022-23, Member Oncology Committee SAFOG, Joint Secretary AFG, and he is Dean AGOG and Chief Content Director, HighGrad.
Thank you, Kanchan. Thank you so much.
I welcome you, sir. Of course, everyone knows you. I don't need to read your CV. Welcome, sir.
Thank you, madam.
Now I would request Komal Chavan ma'am to please welcome our chief guest and guest of honor.
Thank you so much, Dr. Kanchan and Dr. Pradnya. I think they are such a wonderful coordinators I have got. and who have been really very hardworking, and I really am very blessed to have them. And I welcome at the outset all of you to this Trending Ask the Expert series. And today's episode is N. And N, we are going to talk about what's trending topics, that is NCDs and near miss cases. When we talk about obstetrics, we really are now, we are performing well as per the mortality is concerned, but there are still near miss cases, which leads to a lot of morbidity to the both mother as well as the baby. And those cases we need to analyze. We have almost all states have their near miss review also happening apart from the maternal mortality, and that is what is the main point of view of today's discussion. And NCDs, we know the global burden is rising. It is a shift now, and it is a pandemic which is coming into slow motion. We know that.
Alert from login items. Background items added.
So we know, and for this webinar, I welcome all the esteemed faculties who have joined, and I'm so fortunate that we have Professor Padma Shri Dr. Alka Kriplani here with us, because I think when we talk about obstetrics and gynec, and we talk about AIIMS and Delhi, and the Foxy also, I think so many government projects and everything, the name which comes into our mind is Dr. Alka Kriplani. During her tenure as a Foxy president, she has done such amazing work, including the Pradhan Mantri Yojana. I think so many things which government has actually taken, that ties which Foxy has improved during her tenure. And she's currently the director head of the Department of Obstetrics and ART at Paras Hospital, Gurgaon. She had been the former professor, head of the department at AIIMS, and president of, almost apart from Foxy, all the leading organization, that is JESI, DG, AOGD, and also the chair of PIGO Municipal Resort Committee. So total awards are, I think, 47, including the most coveted Padma Shri Dr. B.C. Roy Award, the FRCOG. She's been an eminent spokesperson on so many media platforms, received so many public awards. It's real great. Delivered almost 72 orations. I think the list may be increasing. This is the data which these people have given. And Madam is a versatilist. She's a great teacher and academician, having a field of interest in gynec endoscopy, reproductive endocrinology, and high-risk pregnancy. So I welcome Madam, and I request you to please address our audience.
Thank you so much for your kind words. First of all, I would like to congratulate you people for such a nice A to Z, and today it is N. N is for my dear Niranjan. So let me tell you, with Niranjan,
Thank you,
I
madam.
have very long association. When he was a young, dynamic faculty, so he's still young, dynamic. But then I knew Komal after Niranjan. And the way I think the couple, Niranjan, how he is, he's a good husband, promoting Komal. And I really appreciate you, Niranjan, for this. Because I think without spouse support, one cannot reach. And Komal, I saw your CV today and I was highly impressed. You are doing so much of work. So credit goes to Niranjan also. And I'm sorry if I'm forgetting few names, but the conveners, I think that girl is from Muradabad, which is so near to Delhi, and so many people from North. And these your A to Z series, that Happy Learning series, they are joining obstetricians, gynecologists all over India. And I think it's a very commendable job, because new people get a chance to present their work. And your topic today, this near miss mortality, is so close to my heart, because when you discuss these near miss cases, maximum wisdom you get in managing your future patients. So very, very good topic. But I could see in the program there's somebody speaking on endometrial cancer. That is also, last week I operated 3 cases of endometrial cancer in a week. It's becoming so much more commoner. So your choice of topics, Komal, is very, very good. You have been doing great work in Medical Disorder Committee. And I know behind is Niranjan always, not that you need it, but husband support and working as a team. So we have lovely teams, Pai and Rishma, Narendra and Jaydeep, and you both are the future of Foxy, Niranjan and Komal. Lovely couple. So it's a big pleasure. I have a lot of affections for Niranjan because when I was contesting, he gave me very good insights for so many occasions. And he's always there in all the events. You invite him. I don't know how he manages his leaves. And it's a pleasure. And I wish you all very, very interesting these topics and very happy learning. And I'm sure you all will be updated. And these Shield people are also very nice. They support quietly and they don't force you. So it's a very nice, going to be very nice evening for everybody.
Thank you.
And I wish you all the best, Komal.
Thank you. Thank you so much, madam, for your such a lovely words of encouragement and your blessings. I'm truly honored, and it is always nice. And whenever I call Alka madam, she's so good, you know. She's always so encouraging and willing, and that makes us and the most approachable above all. Whenever we call, madam is always there. Yes, Komal, and I will be there surely. And she's always there, dot on time, every time. So thank you so much, madam, for coming and blessing us.
Pleasure.
And now I call upon our guest of honor, Dr. Sadhana Gupta. Dr. Sadhana Gupta, we all know she has been the co-chair of the SAFOG NCD committee, and she's the most apt person for the webinar focused on NCD, and she has a lot of work also on near miss. She has been the FIGO Foxy representative to SAFOG, Vice President of Foxy in 2016, ICOG Governing Council member with the Best Governing Council Award. And I think she was a chairperson of Safe Motherhood Committee of Foxy, and there also she received the Foxy Dr. Mehru Dara Hansotia Best Committee Award. So she does her best in whatever she chooses, and she's a very hardcore worker, having done our country proud at the level of WHO and quality research, newborn care, received Corion Award 3 times, and research paper prizes, multiple times. I think the tremendous academic work she has done, that is the real inspiring for the upcoming people like us. And definitely, I'm so honored that madam is here today as a guest of honor for today's webinar. And I hand over to her and request her to kindly address all the audience.
Thank you, Komal, for loving and generous introduction. And my thanks to Komal and Niranjan for this invite. And of course, in my 30 years of journey, what a very purposeful relationship we have, and we know in and out each one. So it has been a great journey with Niranjan when he was young and I was also young, and we could do so many things together. And he has invited me to Sion Hospital, and every memory gives you certain things about what is happening in the country, and that's why these associations are so worthy. Dr. Alka Kriplani, my sincere regards to Madam Kriplani. It has a special relationship because I was her vice president, and it is not that only we could imbibe her surgical expertise and the other things, but it was so much things to learn from Madam, from so many things, how to go ahead with the professional organization, how to keep the first people together, and how to go ahead. So whatever I am, a big part of it is due to Madam Kriplani, because being with the great people gives you always something very, very important and permanent to you. So hearty congratulations, Komal and Niranjan, for keeping this LCD as one of your A to Z theme, because South Asia and India, we are really struggling with the non-communicable disease. We are having heart attacks at very younger age, hypertensive disorder, and it is actually the crippling our life, and a lot of emotional, psychological, social, financial, and the healthcare burden to us. So as an obstetrician, why it is so important for OB-GYN that as a OB-GYN, we can intervene in a positive and promotive and protective way at many phases of life. When the girl leads to us in adolescence, that is time for a good lifestyle. when woman comes to us in pregnancy, if she is having any GDM, any hypertensive disorder, that is the time that we don't lose track of these women and always like guard them what they have to do in their life, with the lifestyle, with the regular measurement, with the keeping with the track for the physician. And the near miss, actually, this near miss is something that as a chairperson, we moved from the maternal mortality to near miss when we took the charge from Dr. D.K. Datta and Sheila Mane, and then to saving mother, and then to quality obstetrical care. So near miss is something which gives you insight about like mirror image of causes of maternal death. It gives a learning lesson. It is a positive thing because it is a happy ending and we can learn. Every story tells you what is wrong in our society, what is wrong in our system, what is wrong among ourselves. And every story gives you the point that how we can intervene so that we don't leave the other woman is in the critical or the near miss position. So hearty congratulations, Dr. S.K. Giri. Dr. Basa Mukherjee, my regards to you for coming up with this pertinent topic. Everybody is eager to listen to you. Anupama, Anushri, Dr. Sandhya, Dr. Pranay Phukan. I think all are the very close friends. I was with Anupama last just 4 or 5 days ago, and we are going to a wonderful panel moderated by both of you who are having a good experience, and all we are looking forward to a great discussion and many learning points. So thank you once again for this wonderful opportunity to be with you. And best wishes, Komal, for your upcoming election. Best wishes to you.
Thank you so much, madam. And we wish the best wishes to you too, madam. And thank you so much for coming and gracing the occasion, and your lovely words and the importance of NCD, the who best can highlight it than you, because you have the authority over the subject, and we are so honored with your presence here. Thank you so much. I thank our chief guest and guest of honor. And now I hand over to our dynamic coordinators today, Kanchan and Pradnya. They really have been doing great work, and I'm really happy that they have been conducting it so smoothly and making all the faculties and everybody so comfortable. So over to you, Pradnya and Kanchan. Maybe start the scientific program from now.
Thank you. Thank you so much, ma'am. Now we can move on to the first session, for which I would like to invite my esteemed chairperson, Dr. Anupama Phuttela ma'am and Dr. Anushree Rawal. Dr. Anupama Phuttela ma'am is a president OBGYN Society, Rudrapur, and she has done fellowship in reproductive medicine from NUS Singapore, and she is owner of senior consultant at Phuttela Hospital, Rudrapur. She has gifted first IVF baby to the Kumaon region and primary member of State Surrogacy Board. She has received Best Gynecologist in Uttarakhand Award by Chief Minister in 2022, and she is past Vice President IMA Rudrapur. And she has contributed many chapters to the books, and she is co-founder of NGO at Uttarakhand Board. So I welcome you, ma'am.
Thank you, Kanchan, for the invite, and thank you all the organizers for having me here.
And our next chairperson is Dr. Anushree Rawal Pal, and she has done MBBS MD Obs and Gynae from Government Medical College Jammu and consultant at Anurjun Multispeciality Hospital Haldwani. She is currently Secretary Haldwani OBGYN Society, and she has keen interest in high-risk pregnancy and laparoscopy and infertility. So I welcome both the chairpersons, and now I request Dr. Anushree Rawal to introduce our eminent speaker. Dr. Anushree, yeah. I think there is some connection problem, ma'am.
Anushree, you need to unmute yourself.
Okay.
Hello, ma'am. Can you hear me?
Yeah,
Yes.
I can hear you.
Yes. Ma'am, I welcome our speaker for today, who's going to speak on endometrial carcinoma and its management, Dr. S.K. Giri. He is MD, FICOG. He is ex-president, PG Department of Gynecological Oncology, and former director, AH Postgraduate Institute of Cancer, Cuttack. He has received ICOG Oration Award at Thrissur in 2016, and Mitra Memorial Oration at Kolkata in 2015. He has organized many national conferences and workshops in gynae oncology, He is active participant in many national and international conferences. He has been an operative faculty at many AICOG conferences in gynae oncology and on pre-congress workshops. He's life member of AGOI, FOXY, IMA, IGCS, ESGO, ICO, ISIP, ICGP, and SOFC. He's also member of the Guideline Committee of ICMR, NCG, and NBE. He's president of the Association of Gynecological Oncologists of India in 2009 to 2011. He has been peer reviewer of International Journal of Gynecological Oncology, Indian Journal of Surgical Oncology, Journal of Global Oncology and Cancer Report Review. He has received a Lifetime Achievement Award by AGOI 2021 at TMC Kolkata. He has more than 50 national and international publications, and he has contributed chapters in FOXY books and FOXY focuses. He's an MCH examiner in gynecological oncology at different premier institutes of oncology in India. His special interests are preventive gynecological oncology, vulval reconstruction surgery, radical surgery in gynecological cancers. We welcome you, sir, and we are looking forward to hearing your expert advice and your expert opinion. Thank you. Thank you, ma'am. Thank you, sir.
Thank you, everybody. Am I audible now?
Yes, you
Hello.
are.
Yes.
Yes, sir.
So,
Yes, sir.
So good evening to everybody. Good evening to Niranjan and Kamal and all my chairpersons. I'm privileged to speak in front of President FOXY and incoming President FOXY. So with best wishes to the incoming President FOXY, let me start my topic. I was given a topic of endometrial carcinoma, and so now it is visible now.
Yes, you are. The slides. You can start the slideshow.
Yes,
Yeah, I've done it. So now I've just managed it. It is an endometrial carcinoma and overview. So now what we see, there are endometrial carcinoma can present in different age. It can occur in from different age group to of course it is more common in elderly person. So now as it is a disease of 6th and 7th decade of life, and we know the comorbidities are obesity, hypertension, and diabetes. That is, and we find most cases are more than 50 years, so that is 80 to 95 cases, and median age is 63 years. But nowadays we see a good number of patients coming in younger age group. Even if we see when during investigation for infertility, we are seeing some endometrial carcinoma also, and that is below 30, 22, 35, all things. And the recent years it is increasing now. We don't know how, mostly because of our that is lifestyle, mostly increased obesity, all the diet habits, all these things are there. And when you find it in a very advanced stage, it becomes more aggressive. And we know the present symptoms commonly is the postmenopausal bleeding. And we see when it is when person comes at less than 50 years, around 9% cases of persons come present as the diagnosis as endometrial carcinoma. And as the age advances, at 60 years, around 60% cases, and 70 years old, around 20% cases. And by the age of 80 years, if the patients come with TMB, around 60% cases they are diagnosed as endometrial carcinoma. And like that, in recent years, we have got improved understanding of the endometrial carcinoma, the pathogenesis and everything. And there is a molecular classifications are coming up, and which this classification is accordingly done, and versus conventional, what we used to do just 4-5 years back. And we have got a recognition of after MSI tumor that is sensitive, that is more sensitive to immunotherapy than the conventional treatment. And but their treatment controversy remains that whether we have to do lymphadenectomy routinely or not, and we should select patients for adjuvant treatment to be given or not, if given whether only radiotherapy or concurrent chemoradiation or only chemotherapy or immunotherapy to somebody, and how effective they are. These are a little bit of controversy remains in our understanding. And in all endometrial carcinoma are graded as grade 1, grade 2, and grade 3, depends on different degree of differentiation. And we know the adenostomach tumors, the malignant elements of both granular and stomach epithelium. So presence of stomach differentiation does not affect prognosis. So we know we should have emphasis there. That when you come with adenostomach carcinoma, the people say that it is more aggressive. No, there is no much of effect on prognosis. And carcinosarcoma, previously termed as malignant polarant tumor, nowadays it is obsolete. We are telling carcinosarcoma. It comprises both carcinoma and sarcoma elements, but it is now under endometrial carcinoma staging as per figure 2019 staging system. So now we know. So we have got two classifications. One is histological staging classification. There is endometrial carcinoma, which I told is grade 1, grade 2, and grade 3. And it may be mismatched adenocarcinoma, serous adenocarcinoma, clear cell carcinoma. They are all high grade usually. And mixed clear cell carcinoma and undifferent carcinoma. There are neuroendocrine tumors. Again, we see few applications of neuroendocrine tumor of endometrium. There is neuroendocrine tumor that is well differentiated, small cell neuroendocrine tumor and large cell neuroendocrine tumor. They are all histological classified by doctors. Now, now we are more up to this molecular classification that is in 2013 the Cancer Genomic Atlas came out with this classification of molecular classification. They have got 4 subclass. They that is the whole ultramutated, that is around 4 to 12%. MSI unstable or hypermutated, that is the Lynch syndrome. It is around almost the 22 to 36%. And copy number low, the type 1, the other is called type 1. Earlier it was we divided type 1 and type 2, but now it is lot of divisions are there. This is microcycle is stable. That is 30 to 60% cases are presented in this type of molecular class. And copy number high, that is type 2. Previously it was called type 2. That is presumably they are serious. And we case 8 to 25 cases they belong to this thing. And coming all these groups, we find that all ultramutated have got best PFS, disease-free survival, and copy number high has worst PFS, that is disease survival. But in between two, that is a MSI unstable, and copy number low, they have got intermediate disease-free survival. And we should integrate them into our molecular clinical class or clinical pathological classification. And that is again very interesting that slide that we have integrated this is the histopathological classification low grade endometrial carcinoma into under histological classification, that is copy number low, that is the molecular classification here. MSI is there and pole mutation can be there. But in high grade endometrial carcinoma are usually copy number high. There may some MSI will be there. There will be few pole mutation will be there. But in mostly serious carcinoma are copy number high. And in other, there is clear cell carcinoma, that is carcinosarcoma, they do not have any molecular differences. So that is after the TGCA, it was there's some background noise. So after the TGCA classification, it was found that it is very difficult to come into conclusion to make it, because it is very expensive. So then came out the PROMIS. PROMIS is a proactive molecular risk classifier for endometrial carcinoma. Again, it was easy to substantiate, and it is when it is because ISC scan can be done here from the block project. There is a team from this formalin project block is there, and we can do from that is a MMR protein, there is PMS2 and MSS3, and P53 can be detected in a ISC methodology, and digital PCR can detect the whole exosome domain mutation. So resultant molecular subtypes are whole EDM, which is surrogate marker of whole ultramutated group. MMRD, it is surrogate marker of MSI hypermutated, and P53 the wild type, or NSNT means non-specific molecular classifier, and it is a copy number low, and P53 abnormality is there, it is under the copy number high. So accordingly, it was suggested and recommended that any case of endometrial carcinoma should have some molecular profiling to be done. So first we should go for the MMR. MMR, if it is whether MMR deficient or not, is MMR-D or MMR intact. If there is MMR is not detected, this would be, it is called.
मैंने कहीं दरवाजा कैसे खुला हुआ है, तो मैं इसको करने में मैंने कहा देख के आऊं उधर। नहीं, हम उधर बैठे थे ना, फिर इस पे लगे हुए थे।
Can anybody mute?
वो दे एक्सेस दे, तो इसका मैं वो नहीं दी हुई थी।
Can anybody mute?
Organizer, you need to mute.
because there is a background noise.
क्या करें?
Yeah, host, kindly mute.
Yeah. So now if it is a MMR deficiency or MMR intact, if MMR intact is there, we should go for a pole mutation. If pole is mutated or pole is wild type, pole is mutated, we call pole EDM.
फोन कहाँ से उठाऊं? पता नहीं कहाँ से.
Host Shield Connect, kindly mute Dr. Abha
हाँ.
Singh and others.
Okay.
WhatsApp पे था.
Dr. Abha Singh, can you mute yourself, please?
I'll call madam and tell.
Okay. So either pole mutated or pole wild type. If there is a pole, you have done everything, but pole is wild type, then one should take P53. If it is 1 plus, it is called P53 wild type. If 0 or 2 plus, we call P53 abnormality. So accordingly, one can think whether if a patient which is having some endometrial carcinoma belongs to MMRT, pole EDM, or P53 wild or P53 abnormalities, they are not. Depending on which we classify or restratification can be done. So now, and WHO has classified from 2014, it was there. The classification was what I told earlier, endometrial carcinoma, SAMAS, Gilograndular, secretary, mucinous, all these are there. But in 2020, it is classified, that is again pole alter-mutated, mismatch repair, endometrium, P53 mutated endometrial carcinoma, and NSMC. And so this integration of molecular parameters into standard pathology reporting by WHO in 2020, it is imperative that the world is now aware of the rationale of molecular subtypes of specific hair. So now the world is now after the molecular subtypes of an endometrial carcinoma. So now let us come to what is the management. So management is a treatment. Surgical stitching is the treatment of choice in endometrial carcinoma. And we know the mandatory workup should be family history taking, and clinical examination, including pelvic examination. Good TBS is as good as MRI. So MRI is preferred. With MRI, we should know what is primary tumor diameter, maya invasions, cervical extension, adenosine involvement, and nodal status can be assessed with MRI. And endometrial biopsy should be done after that. That is, we should know the bed type and molecular subtype, which can be detected from very beginning. From the endometrial biopsy, one can do for molecular subtype. And optional period to WhatsApp are other imaging like thoracic, abdominal, and pelvic CT scan. PET CT scan is not always recommended. It is always recommended in a recurrent setting mostly. And serum tumor marker has no value unless it is a extra abdominal disease. So other advanced workup could be universal testing for MMR. This is recommended that we should first go for MMR in almost all cases of endometrial carcinoma. And if there is MLH, one loss is there, we should further evaluate other MSH1, MSH6, all these things. And genetic counseling testing for all other MMR abnormalities should be done. And if there is no abnormality of the MMRT is not there, but there is strong family history and genetic family history of breast, ovary, endometrium, colon cancer, once the genetic counseling and testing has to be done. And once in ACR staging, it usually required stage 3 and stage 4, because we know there is no much of hormonal treatment in early stage endometrial carcinoma and in recurrent carcinoma also. So this is a NCCN guideline. So universal testing for endometrial carcinoma for MMR proteins MSH is recommended. And also they say those who are MMR inactive or MSH stable, and those who have not been scanned but who have strong family history of endometrial or colorectal cancer, genetic counseling testing is recommended. So the question comes, surgical, how to go for surgical management. There is a broad principle is pre-operative management. We have got information of type of the disease, grade of the disease, and imaging findings, and also molecular features of the endometrial carcinoma. So once you go for surgical pathology staging procedure, one can nowadays commonly the MIS is indicated. That is either laparoscopy or robotic. But if facility is not there, one should go for laparoscopy. But outside the uterus, when a disease is outside the uterus and cervix, including lymph nodes, they are relative contraindications for MIS, but this is relative. Expert can do it. And one is very careful. There should not be any intraperitoneal tumor spillage, even tumor rupture, and morcellation should not be dane, even if endobag. And uterine manipulation should be avoided. So So doing intraminimum with lot of spillage in the peritoneal cavity. And if vaginal extraction, the risk of uterine rupture, when you are in large uterine tumor, there is a chance of uterine rupture or uterine mercilation. So better we should avoid it, and one should remove it with mini laparotomy and use endobag, and it should be not the mercilation should not be done. And one should on laparotomy or laparoscopy, what to do? One should peritoneal fluid of saline phase to be done 100 to 120 ml for cytology. It is cytology positive fluid has got no meaning, but nowadays it is being done, being collected to further record keeping. So intraabdominal organs access and node palpated. If one should go for a type 1 hysterectomy with bilateral salpingo-oophorectomy. Salpingo-oophorectomy should be done because the micrometricis is around 5 to 8%. Okay, ovaries can be preserved in young, but in grade 1 adenocarcinoma, less than 50% my invasion, and not recommended when there is patient is having AXA mutations or Lynch syndrome, and along with ovaries can be preserved, but salpingo has to be done. And type of hysterectomy may be simple. People are telling whether type 1 or type 2, type 3. There is no need of doing all the type 2, type 3. Even if service is involved, even if stage 2 disease, there is no need of doing type 2 hysterectomy or type 3 hysterectomy. Only simple hysterectomy or type 1 hysterectomy can suffice. But there is no impact on local regional control survival. Intraoperative progesterone is not encouraged for my invasion. That is not. It is already predetermined by doing MRI. One can know whether my invasion is there, less than 50%, more than 50% my invasion there. One can easily know. And if you do intraoperative progesterone, there it will interfere with adequate pathological processing, and there will be not good report will not come. So omentectomy is a procedure which is not always done in the case of the endometrium, but it is done mostly there is a serious endometrial carcinoma, carcinosarcoma, non-differential carcinoma, and grade 3 histology. That is nobody is recommending, but ICMR 2020 recommending in doing grade 3 study wants to go for a omentectomy, and when there is adenosine involvement. But omental biopsy, as per Einstein guideline, they say, and omental biopsy should be done in a serous carcinoma, clear cell carcinoma, and carcinosarcoma. They do not do systematic omentectomy, but they ask for, we can go for omental biopsy, and it can be omitted in clear cell and endometrial carcinoma stage 1 disease. And in an advanced stage disease, one should go for a total omentectomy and to achieve complete microscopy. And surgical restaging, supposing a person has come with hysterectomy done without knowing that he is having endometrial carcinoma, so done vaginal hysterectomy, ovaries conserved, all these things are there. So if it is incomplete stage, it is not complete stage, only hysterectomy is done. So we should look into all the factors which is there in the uterine factors to be done, whether it is a high or intermediate risk, whether it is a high risk disease is there or not. If it is a grade 3 disease, better one should go for consider for surgery. If it is a high intermediate risk group with a invasion more than 50%, and one should the adenosine are retained there, one should go for the division surgery should be done, and one should weigh the outcome of the infection of the adjuvant treatment strategy is overweighs the surgery. So in a stage 2 disease, there is no need of type 2 or type 3 hysterectomy. Only it is required when the parameter is a little bit involved. When we have to remove the parametrial tissue, there is the role of type 2 or type 3 hysterectomy, but there is not always required at all. When parameter is not involved, one should go for only simple or type 1 hysterectomy. And appendectomy or peritoneal biopsy done in a non-endometrial carcinoma, and when it is involved by endometrial carcinoma. So now there is a controversy and consensus of systemic pelvic lymphadenectomy. No therapeutic role of lymphadenectomy. It should be known there is no therapeutic role of lymphadenectomy, but it is an integral part of comprehensive surgical stage. So it becomes very difficult to conceive it. So lymphadenectomy is a part of comprehensive surgical staging. It is for better definition of prognosis and appropriate triage of patients for adjuvant therapy. It is a prognostic information. There is no therapeutic, rather a prognostic. If indicated, so when lymphadenectomy is indicated, we should go for pelvic and para-aortic. And pelvic and para-aortic, the systematic pelvic and para-aortic lymphadenectomy should be done up to left renal vein. It has to be done. When when he is on doing pelvic lymphadenectomy, when you see pelvic node metastasis is there, so with pelvic lymphadenectomy should be omitted at only remove the enlarged lymph node, but one should address the para-aortic lymph node, because we know, I'll come little later on. And lymphadenectomy, because we do not do lymphadenectomy because there is increased morbidity, increased lymphedema, increased dysphoria, all things will come out, and there is a prolonged surgical time, and there will be bleeding or injury to the vessel. So then what happens? When lymphadenectomy could not be done, there is lymphatic controversy there. So things came out to be sentinel lymphadenectomy. Sentinel node is a acceptable alternative to systematic lymphadenectomy in stage 1, 2, and lowered intermediate risk without obvious extrauterine disease. In no evidence of distal metastasis or nodal disease on imaging, it omitted. Omitted in cases of when there is no myelinvasion, we may omit the sentinel lymphadenectomy, and Frozen is not advocated. What is advocated now? If you're doing it sentinel lymphadenectomy, sentinel node mapping, just remove the sentinel positive node and leave it assess after doing hysterectomy, and do later on. If the sentinel node becomes positive, anyhow you have to go adjuvant therapy. So there are many issues. So presence of both micrometastasis and macrometastasis is regarded as metastatic involvement. When there is ITC is not nowadays not regarded much. So this algorithm is there. Peritoneal and serous evaluation is, and washing has to be done. One or two sentinel lymphadenectomy. And rectoperitoneal evaluation has to be done. We should open the rectoperitoneum and excision all mapped sentinel node with ultrastaging has to be done. All mapped with sentinel node mapping is there. We should remove the ultrastaging, and any suspicious nodes must be removed regardless of mapping. So if there is no mapping of a hemiplegia one side, there is no mapping of sentinel node mapping not there, means sentinel node is not taking color. So this side specific lymphadenectomy has to be done, to be performed, and one should not go for the frozen section. So now there is a question: do only pelvic lymphadenectomy? And there is a Barrack and Hecker in 2020 in their book. They tell they advocated the one to do only pelvic lymphadenectomy when and when grade 2 tumor with more than 2 cm tumor diameter. So, but when pelvic nodes become positive, one can think of going for para-aortic. The rationale is that pelvic node or nodes positive, the risk of para-aortic lymphadenectomy is around 50%. And negative pelvic node, the risk of para-aortic is around 2%. So when pelvic node is negative, perhaps only hardly 2% cases will be para-aortic positive. So they have advised only pelvic lymphadenectomy in the case of endometrial carcinoma, mostly in a endometrial adenoma. So now question comes: lymphadenectomy should not be done in a grade 1, grade 2 diseases as a feature of myelinvasion on no evidence of extrauterine disease and absence of cervical involvement and primary tumor diameter less than 2 cm. But it should be done in a grade 3 tumor, phase 2 cases, evidence of extrauterine disease, non-endometrial adenocarcinoma, depth of myelinvasion is more than 50%, and when pelvic node is positive on pelvic lymphadenectomy and cervical extension, or previously incomplete stage high risk, there are the situations where one should go for pelvic lymphadenectomy. So summary is there: systematic pelvic lymphadenectomy and para-lymphadenectomy to be considered when myelinvasion is more than 50%, FIGO grade 3, and there is cervical extension and evidence of extrauterine disease. Incompletely operated high-risk patient lymphadenectomy to complete staging could be considered to tailor adjuvant therapy and non-endometrial adenocarcinoma and carcinosarcoma. And lymphadenectomy not required in a grade 1 and grade 2 disease, less than 50 myelinvasion and tumor diameter less than 2 cm in grade 1 and grade 2. So it has got a lot of, again, the question comes whether you can do fertility preservation there. It is there. There is always a scope of fertility preservation, and so when is it in either atypical hyperplasia or EIN or grade 1 endometrial carcinoma, there is a possibility one can go for a fertility preservation. In these patients, endometrial biopsy, preferably through hysteroscopy, should be done, and in these cases, they must be confirmed diagnosis by pathologists, especially gynecological pathology, and radiologic imaging to assess the extent of the disease must be performed. An expert ultrasound examination can substitute pelvic MRI. If there is myelinvasion, we should avoid doing anything fertility choice. Patient must be informed that fertility sparing treatment is not a standard treatment. Patient must be willing to accept close follow-up and be informed of the need for future hysterectomy in case of failure to treatment. And histoscopic resection prior to progesterone therapy is done. Metrosy progesterone acetate 400 to 600 milligram per day, or megestrol acetate 150 to 320 milligram per day is recommended. And levotestosterone internal devices to be, if it is given together along with progesterone, must be better effective. And so it will come for again histoscopic biopsy after 3 to 4 months. And after 6 months, if it is not responded, we should avoid giving any conservative therapy. And now management of stage 3 and stage 4 disease, it is again tumor developing can be done, enlarged lymph nodes should be done, primary systemic therapy could be used in a stage 3, stage 4 diseases. If a good response to systemic therapy, one can delay surgery can be done. And systemic lymph is not recommended in stage 3, stage 4, and primary radiation therapy is preferable in some cases. And so risk stratification as per molecular classification is not known. After surgery, the patients are categorized into 4 risk groups based on tumor type, stage, grade, and LBSA. The treatment system depends upon these groups. Their risk groups are low risk, intermediate risk, high intermediate risk, and again it's classified into 2. What is lymph node staging is done, lymph node staging is not done, and there is high risk. These are the situations where we can treat. So this is a very interesting. It is little bit busy, but in a low risk there is no treatment is given. In intermediate risk, that is adjuvant brachytherapy can be given, but it can be omitted in less than if the age is less than 60 years. And if it is in high intermediate risk, if the lymph node staging is done, but there is no N0, mostly adjuvant brachytherapy can be given. EBRT can be given in LBSA stage 2, and adjuvant chemotherapy can be considered, especially in high grade and substantial LBSA. And omission of any adjuvant treatment is an option also. When lymph node staging not done, usually we should go for brachytherapy, EBRT, external beam radiotherapy. And high risk, definitely we should go for external beam radiotherapy, or there is concurrent chemoradiation, or only chemotherapy. Carcinosarcoma, better to go for chemotherapy. And molecular markers is the need of the day. And molecular classification is encouraged in all endometrial carcinoma, especially high grade tumors. And pole mutations analysis may be omitted in low risk and high intermediate risk carcinoma with low grade histology. But if it is high grade histology, one should go for a polymutation. And that is depends upon this 2020 guidelines is there. And a low risk group that everybody that you can go through this article. And if there is, but in the stage 1, stage 2, and stage 1 cases is a low risk, but stage 1, stage 2 polymutated. In stage 2 cases, with polymutation is there, it is included under low risk group. That's very important. This is the term of molecular classification. And there is no change in 2016 classification. And intermediate in this group, again, it is done. It is in the high grade. It is stage 1 endometrial plus high grade, and but LBSA is negative or local. And it again, if it is a MMRD or NSM treatments, that is non-specific molecular profiles, and these are all, if it is P53 abnormality there, again it comes under intermediate group, but there is no myelopathy. I'll come in high intermediate group is almost same thing. Do you know what is substantial LBSA? When on pathology, there is under microscope, if there is more than equal to 4 LBSA involved in vessels at least in one HCG is called substantial LBSA. This is stage 2 is now included under high intermediate. Earlier it was in high risk group. So now if it is stage 2 disease, one should be again very careful about it. One can treat only brachytherapy, or if it is with a substantial LBSA is there, one should go for a EBRT. So high risk group always it requires EBRT or concurrent chemoradiation. And in the advanced stage, again it is almost a palliative treatment has to be done. And then how to treatment, who to do, what adjuvant therapy has to be given. Is there any risk of relapse? We should after surgery we should think whether is there a risk of relapse. If no, if there is not unlikely, one should observe. If there is any risk of relapse, there is possibility risk of relapse, one can say what is the height of relapse. If it is vaginal relapse, possibility is there, one should give for brachytherapy. If it is pelvic relapse is there, one should give for EBRT. If it is distant relapse, so question is distant relapse is there. Mostly it occurs in a non-endometrial variety carcinoma. There is distant relapse is there. So here is the role of chemotherapy. If it is a local plus distance is there, one can give for radiotherapy plus chemotherapy. So adjuvant treatment in low risk, there is no treatment is required. Even if stage 1, stage 2 cases with pole mutation, there is no need of adjuvant treatment is there. But in the intermediate risk group, it is only adjuvant brachytherapy indicated, and it can be aborted in less than 60 years. But if there is p53 abnormal, it is regarded as a high risk. But if it is occurs in a polyp or polyp without myoinvasion, one can think there is no treatment is recommended. Even if p53 abnormality is there. So in a high intermediate risk group, when after lymph node staging, there is no lymph node is there. Again, adjuvant brachytherapy is given, but EBRT means external beam radiotherapy is given when there is substantial LVSI for stage 2 disease. There is a possibility, there is a situation where you can give. And adjuvant chemotherapy can be considered especially for high grade and substantial LVSI. And when there is lymph node staging is not done, usually we give EBRT. Mostly, when staging is not done, we do not know anything, and we should give the EBRT. And adjuvant chemotherapy can be considered, and adjuvant brachytherapy alone can be considered for high grade LBSA negative, high grade disease, but LBSA negative and stage 2 grade 1 anemoted carcinoma. One can think of brachytherapy only, but these are all individualized. For high risk, EBRT and chemotherapy can be given. And advanced cases, I know this is all palliative treatment. And this is very interesting case. In this, I told the low risk cases, brachytherapy should not be given. There is no treatment for brachy or external beam or chemotherapy. In intermediate, again, one can give only brachytherapy, but there is no indication for giving external beam or chemotherapy. But high intermediate, when lymph node is negative, one can think of giving brachytherapy only. But in the substance of LBSI or stage 2 disease, one can think of giving external beam. It is all individualized. But in chemotherapy, is not required unless in grade 3 disease or there is substantial LBSI. The high intermediate risk group, when there is no such staging is done, usually we should give brachytherapy followed by also EBRT has to be given, because we are not very much sure about it. High risk, definitely there is chemoradiation. In high risk with node, there is a Q1 means one pelvic node is positive, one should give chemoradiation, and chemotherapy can be as per protective protocols. There is a period of chemotherapy followed by radiotherapy with concurrent chemoradiation, and stage 3 to C2 means on a parent node is involved. There is one can go external beam radiation and concurrent chemo. So these are again a rainbow trial. They tell if there is a p53 abnormality is there, one should give chemoradiotherapy or chemoradiotherapy with targeted agent. That is a PARP inhibitor can be given. If MMRD is positive means that is so one can give radiotherapy or radiotherapy plus PD-L1 inhibitors. That is a pembrolizumab can be given. If there is non-specific molecular profile is there, one can chemoradiotherapy and radiotherapy. Like that, one should think of it. And this is again a very interesting topic regarding that is a molecular classification. If MMRD is there in a patient's MMR deficiency is there, in early stage there is no need of NAT means no adjuvant treatment is required. But in high grade disease, advanced disease, adjuvant RT is better than concurrent chemoradiation. In a MMRD, they require only RT if it advanced stages, but concurrent chemoradiation should not be given because it does not have much of effect. Rather, it has side effect. Here is the role of immunotherapy. One can give in MMRD positive case. But in pole medium is there. So in low stage, stage 1, stage 2, or high grade. In high grade tumor, low risk is there. So no adjuvant treatment. In advanced stages, there is not yet defined what to give. A concurrent chemoradiation, so only RT is favorable outcome. There is a role of fertility sparing option is there. In a p53 abnormalities, that is again very difficult situation. If it is usually a high risk group, and this concurrent chemotherapy is recommended plus minus radiotherapy. And p53 with no myoinvasion limited to polyp, it is the intermediate risk group, so no adjuvant treatment is required. On p53 wild type, there is a role of fertility sparing treatment. And NSNP is because it is not non-specific for molecular profile means it is as good as we are doing histopathological profile. So we can give as per histopathological risk factor, one can give adjuvant therapy or not. And there is a multiple classifier that is called pole plus p53 abnormality is there. But it's when pole and p53 is there, we should manage with pole mutant. If MMRD plus p53 is there, one should consider MMRD in early stage. And there may be all three are there. Only MMRD pole mutation and p53 is there, and it is the cascaded pole mutation and it is classified as co-limitation, and that is infection data to treating such patients. And one can do hormone replacement therapy because the recurrence is occurs mostly after 2 years, so better to start HRT after 2 years. Conjugated estrogen, etc., can be given after 2 years of treatment to completion. However, Raloxifene can be given. And post-treatment surveillance should be done 3 to 6 in all malignancy, mostly 3 months interval should be for 2 to 3 years, then 6 months for another 3 to 5 years. After that, annually. And each visit one should do clinical examination, television examination, and pap smear. But other investigations, ultrasonography, CM should be not done, but should be done when there is considered appropriate. When there is recurrent disease, again depending upon situation, if it is a peritoneal lymph node developed, should be considered for surgery only if it is anticipated that complete removal of microscopic disease can be achieved with acceptable morbidity. If the local regional recurrence is there, the third primary therapy should be EPRT plus chemotherapy with brachytherapy, and easily accessible superficial vaginal tumor can be receptor vaginal. Adjuvant hormone treatment has got no value. It is yet to multiple clinical trials and meta-analysis exploring the potential benefit of hormone treatment adjuvantly in high risk endometrial carcinoma do not show any benefit. Endocrine therapy is not recommended as postoperative adjuvant therapy. It is recommended in recurrence. So targeted therapy is nowadays anti-PD-1 plus immune therapy. Pembrolizumab would consider for second-line therapy in MSI, MMR carcinomas. I told earlier, and it can be done in the other done in the second-line treatment of microscopic stable carcinoma also. So what we have learned so far, we have moved beyond histopathology, this category to molecular classification. This is the call of the day, and it advocated all endometrial carcinoma. This allows assessment of treatment efficacy with a biologically similar tumor. Now what happens? It identifies the poor prognostic markers. Means P53 in low risk. If you grade stage 1 disease, grade 1 disease, if P53 positive, then it becomes a high risk now. So it identifies poor prognostic marker. The P53 is poor prognostic marker in low risk patient, but good prognostic marker is poorly mutation in high risk patient. If it is stage 2 disease and it is poorly mutation, it becomes a low risk. You may not give any adjuvant therapy, and it prevents over and under treatment. Polymutation analysis may be omitted in low risk and intermediate endometrial carcinoma in low grade histology. So polymutation high grade is the low risk. In high grade histology, in grade 3 tumor, if polymutation is there, it is a low risk. Polymutation in stage 1 and 2 is a low risk. Polymutation in endometrial adenocarcinoma carcinoma in stage 3 and stage 4, there is no data what to do. If there is polymutation in stage 3 and stage 4 diseases, we do not have much of data. And let us comment it. So let us end here with more evidence for selecting adjuvant therapy, that is radiotherapy, chemotherapy, and targeted therapy based on molecular classification and endometrial carcinoma are needed. And results of ongoing and future trials investigating adjuvant and targeted therapy for ECR legally awaited. And we are waiting for Protect 4A in 2023 may answer this issue. And most probably we are waiting for the day what is the best treatment. Still there is a controversy in management of endometrial carcinoma, starting from adjuvant treatment, lymphotomy, all this. Thank you so much for patient listening. Thank you.
Thank you so much, Dr. Giri, for such a detailed description. You know, this endometrial carcinoma, so many new things have come up, so many molecular basics have emerged. Most of us gynecologists, I would say, who are of yesteryears, I should now say, especially the infertility people and all, we don't even know about these new molecular POL and P53, all those subgroups which are mandatory now. And you have really sensitized us so well. And I should actually thank the organizers. You know, you have brought up a very pertinent topic. There's so many new things. Even this 2020 classification, a new classification has come up. We were not yet aware. So that is a very good thing. And thank you all the organizers, Dr. Chavan, Dr. Komal, Kanchan, special thank you to you. Thank you, Dr. Giri.
Thank you very much. Thank you.
Sir, I have a question.
Yeah.
Hello, sir. It was a very comprehensive lecture, sir. It was very nice. I just want to say that supposedly we do an endometrial biopsy and we detect somebody with an endometrial cancer. So in a small setup like we have mostly here, are there some cases that we can operate in the setup, or should we refer all the patients of a positive histology to Cancer Institute?
No, if you,
I
if you
just
could-
some
yes,
rough outline of what all should
yeah.
we do.
Yeah.
Not much
Yeah.
time, sir.
So,
Sorry. Yes.
if it is a grade 1 disease, and grade 1
Yes.
endometrial carcinoma, if a grade 1
That
endometrial
means
carcinoma,
no myometrial invasion.
Yeah.
That is what you.
Yes. Grade 1.
yes. But
So,
again, you have to go for either a good
what all
ultrasound.
should we look in that report? That report which the
Yeah.
pathologist gives us. Many a times it's not complete report. So what
Yeah.
should we basically ask
you
for?
ask for-
We
you
know that
ask for-
grade 1
yes.
tumor. Yes.
You ask for the, I need the type of tumor, whether it's endometrial
Yes,
or
yes.
non-endometrial. I should know
Yeah.
the grade of the tumor. If
Yes.
it's grade 1 disease and endometrial variety, anybody can do hysterectomy. Because there is
Okay.
no need of lymphadenectomy, all this only, but try to remove the ovaries. So it
Yes.
one can anybody can do it. But again,
And,
there is some grade
Yes.
science. Means one will do the biopsy specimen grade 1 can become grade 2. And there
And
are
what
there are-
else investigation should we do more? Like we should do
So,
an MRI, CT and all, right?
Only MRI. MRI can give you pelvic MRI can give you lot of information regarding size of the tumor, the maya invasion, cervical extension, stromal invasion, parameter extension, adnexal involvement, and lymph node involvement. All these MRI can give. But again, a good ultrasound can give all the information also. But good, who is good? Not possible to know. It's very difficult. But again, MRI should be the basic investigation in a case of endometrium before going for any surgery.
Thank you.
Thank you.
Thank you.
Thank you.
Uh,
Thank you so much,
thank you,
STG sir, and
Thank you,
chairperson.
Giri, sir. Thank you, Giri, sir, for coming.
you,
for
thank you.
us. And really, you have done a lot of efforts and work. I have visited Odisha, I have visited Cuttack, Bhubaneswar, and I've seen you that you are something more than, a teacher for even Janmajay Mahapatra, Bhagyalakshmi Nayak, and
Oh.
of course, all of them have been your students, and it's really great that you're doing a wonderful job, and we are really thankful to you for sparing your valuable time.
Thank you very much for asking me. Thank you.
Thank you so much, sir. Now I hand over the session to Dr. Pradna.
Good evening, everyone. I thank the speaker and chairpersons of the previous session. And now we move on to the next session, which is on obesity and reproductive health. For this, I would like to invite the chairpersons, Dr. Sandhya Saharan and Dr. Pranay Phukar. Welcome, respected chairpersons. Dr. Sandhya Saharan is the immediate past president, Thane Obstetrics and Gynec Society. She is an honorary joint secretary, PCOS Society of India. She has special interest in endoscopy, PCOS, and infertility. She is a consultant obstetrician and gynec at Jupiter Hospital, Thane, Hiranandani Hospital, and Kaushalya Medical Foundation and Curie IVF. She received several awards and has several publications to her name. I now invite the next chairperson, Dr. Pranay Phukar. Sir is a professor and HOD at Lakhimpur Medical College, Assam. He is an undergraduate and postgraduate teacher, university examiner, and has been an ICOG visiting professor. He has also received the AOFOG Young Scientist Award and has been the president of Dibrugarh Obstetrics and Gynec Society and has several publications and awards to his credit. Welcome, sir. I now request the chairpersons to introduce our speaker, Dr. Basab Mukherjee, sir.
Thank you so much, Pradnya, for the kind introduction. And thank you to Dr. Chavan and Niranjan as well as Komal for inviting me for this fantastic webinar. It's my proud privilege to introduce Dr. Basab Mukherjee. As we all know, he has been the Vice President of FOXI 21-22, Vice President Bengal OBGY Society, member of the ICOG Governing Council from 2015 to 20, Secretary AICC RCOG India East, FIGO Coordinator South Asia Safe Abortion Committee, Founder Secretary IAGE Bengal, Organizing Secretary of the recently held AICOG 2023, Young Gynecologist Awardee AFOG 2011 at Taipei, and contributed more than 30 chapters in textbooks. So I welcome you, sir, to give a very, very interesting lecture
Thank you, Sandhya. Thank you very much. So thank you to the multi-talented Dr. Sandhya Saharan from Thane and our dear friend Pranay from Dr. Pranay Phukan from Dibrugarh. Thank you very much for being here. Thank you, Niranjan, and thank you, Komal. And just 2 words about Komal. I think she's been an excellent chairperson. When I've been the vice president of Foxy last year, we've seen her working tremendously hard, and I'm sure that all the good work that she's done will be considered, and when you will be electing her as the vice president of the West Zone. So she's an excellent work. She's a great worker, a great team player to works with other people and gets things done. So we just hope her all the best for her the upcoming elections. Thank you, coordinator. Thank you, Pradnya. Thank you, Kanchan, and just taking it forward. I do get the hint why you've given me this topic, and I think I'll try to work on that. And just taking cues apart, I'll just try to share my slides. Thank you. So over the next 20 minutes, I won't take longer than that. I'll be running you down through some issues of something which we don't always discuss every day, but at the same time, over the last decade, I would say this has become an integral part of any seminar in reproductive endocrinology. So in reproductive endocrinology, whenever we have a discussion, obesity invariably comes in, and it becomes a part of the discussion, whether it's obesity and PCO, obesity and subfertility, or now in this particular case, obesity and reproductive health. So India needs to lose weight, and we don't. We understand all of that, and that's why losing weight and weight loss is a multi-billion-dollar industry. And in India also, it's no different. So you have your health and wellness centers, and there are 100 of herbal drugs over the counter which claim to have a lot of weight reduction and help you to get into your optimal weight. We know most of that doesn't work. A lot of people love to waste money, and there are different ways to do it, but ultimately it goes down to the hard work of diet control and exercise. So 73% of urban Indians are overweight. Almost half of urban Indians are obese, and you don't have to do much. You can just look around wherever you're going out. You can see whether it's in the mall, whether it's in a conference, whether it's everywhere. You can see the bulging bellies, and those aren't in the best interest of good health. So the average Indian needs to lose around 11 kgs, and so it's really, that's bad statistics which we need to look out. And BMI is the traditional thing which we do for calculating the obesity, the extent. So height in meters squared by weight in kg by height in meters squared. We know that. And the BMI, as you know, above 25 is what is considered obese in a South Asian or an Indian population. So it's not 30 as it was used to be before. It's now 25. Some people even say less. And the basics of weight gain, as we all know, goes down to the basic thing of energy expenditure, and input is much more than the output. And that is, there's no difference, and there's no shortcuts. There's no easy ways out. It goes back to the difficult ways, whether it's intermittent fasting or whether it's any other food fad that you may consider. It all goes down to very hard work. So how does the adipose tissue change the reproductive health outcome? That is what we understand. What is what we need to know and understand. And over the last decade or two, we have understood that the adipose tissue in the human body is also acts as an endocrine organ. And that is something which is new, which a lot of people don't always think in that way. But adipose tissue is considered an endocrine organ, and it secretes various types of bioactive cytokines, namely adipokines, and those have an important role in reproduction, immune response, and the metabolism, glucose and lipid. So in the family of adipokines, there are adipose-specific cytokines like leptin, which everybody knows about, and there's also some other cytokines there, and there's non-adipose-specific cytokines, the ones which are mentioned here. And the abnormal levels of these are strongly associated with insulin resistance, type 2 diabetes, and polycystic ovary syndrome. So the functional property of adipocytes, that is the fat cells, they would be resulting in hypertension, dyslipidemia, formation of cancers, increasing risk of type 2 diabetes, thrombophilia, inflammation, and atherogenesis, all the bad things which you can think of in the metabolic syndrome. A lot of that can be correlated to increased adipose tissue. The other part which increases a lot of these NCDs is your lifestyle diseases, whether it's smoking, whether it's alcohol, whether it's drugs, whether it's a sedentary lifestyle. But then you add this obesity to it, and then that also brings it to a different level. So how does the major effects of adipokines in the fertility of obese women? Well, leptin increased levels inhibit insulin-induced ovarian steroidogenesis. Adiponectin decrease causes plasma insulin levels to increase. Resistin increase causes insulin resistance and the like. So there are various adipokines which act differently, but all causing insulin resistance. And that is something which is negatively influences the functioning of a female reproductive organ system. How is it related to subfertility? This is just some of it. It acts at the follicular level, where there is early follicle atresia, delayed meiotic maturation, increased aneuploidies, increased follicular apoptosis. This is not something which you can see externally. It causes stromal decidualization, and it causes increased insulin resistance, hyperinsulinemia, decreases gonadotrophs, decreases SHBG, and that is how it really links obesity with subfertility. So impact of obesity on key reproductive functions. One of the functions which we see when we talk about adolescent girls and the high volume of PCO now any average gynecologist sees is weight gain and menstrual cycle abnormalities. And this is something which we have learned from our postgraduate days. But over the last 2 decades, we see increasing number of teenage girls and adolescents or young adults coming with menstrual problems. A large amount of that can be related to their extra weight gain. And menstrual irregularity occurs more frequently with women above 175% of ideal body weight compared to women below 150% of ideal body weight. And it differs. So it's 54% there and 19% there in one of the studies done some time ago. Obese women in general population have a higher incidence of menstrual irregularity and a lower chance of conception within 1 year of stopping contraception compared to normal weight women. So a lot of these women would be on a contraceptive pill, possibly before marriage, possibly before sexual debut, because of regularizing of cycles. And that is something which they would be continuing after marriage. And once they stop it, the chances of reverting back to the essentially depend on, in the interim, how much of weight loss or how much they have managed to achieve. So in many cases, they don't achieve that weight loss. Sometimes they increase weight. And in that case, after they stop the pills, they again will get back to their previous rhythm, which isn't quite regular. So here, this is one of the stats here. 66% of obese women conceive within 12 months compared to 81% of normal weight. So ovulatory dysfunction obesity is commonly associated with ovulatory dysfunction. Obese women with a BMI of more than 27 have a relative risk of anovulatory infertility of 3.1. So the confidence intervals here are all beyond the 1 range, 2.2 to 4.4, compared to their lean counterparts. And this is something which we know. There are a lot of people who come with obesity, but just having a look at them, you know that they are the come for, and they're arriving for subfertility. It's very related, very likely to be related to anovulation. So then comes your various ovulation induction drugs. So here, case control study of 2,500 plus women with anovulatory subfertility with 46,000 controls showed a relationship between the increasing BMI and increasing relative risk of ovulatory dysfunction or anovulation in women. Altered endometrial function. They also suppose obesity appears to alter endometrial receptivity during IVF. And that is something which we have seen. And this is a different pattern of endometrial gene expression during implantation than lean women, which is more pronounced in infertility. The other part of obesity, besides menstrual menstrual irregularities is related to polycystic ovary per se. And in women who are genetically predisposed to develop PCO, which are a large number of women in India, we can say around at least 1 in 5 to 1 in 6 women are prone to develop PCO. Weight gain and obesity often results in its clinical and biochemical manifestations. So genetically predisposed, environmentally modified disease is polycystic ovary, where the predisposition is there in the genes, but till your weight gain doesn't come up, it doesn't go into a full-blown disease. But that again comes with the irregular periods, with the hirsuts, with the other features of hyperandrogenism, and along with them with the subfertility later. So there are close links between obesity and PCO. We know around 50% of PCO women are obese clinically, and their weight loss is one thing which definitely can help them to achieve the problems of PCO that they have, which could be anything from irregular periods to subfertility to hyperandrogenism. So in one of these studies, 38 to 88 are either overweight or obese, if you want to bring both of them in together. So the mechanisms linking obesity and PCO are many, and this is a big chunk of a mouthful of the diagram, where adipokine release, OSA, insulin resistance, again, a lot of other things, genetic factors, ovarian dysfunction, where there is connections between obesity and PCO, most of which we are aware of and we know. So the clinical features of obese women with PCO, there is an aspect of androgen abnormalities, where various studies have evaluated the impact of obesity on hyperandrogenic state in women in PCO. So if there are women who have who are overweight and who have androgenic problems, they can achieve a eutandrogenic state if they lose weight, and that helps in decreasing the acne and the hirsuts, etc. A lot of women will not wait that long, and then you give them the medicines which are the anti-androgens, or you give them the anti-androgenic OC pills, which are generally cyproterone or drospirenone. So they uniformly demonstrate that obese PCO are characterized by significantly lower SHBG, so more free androgens in the system, and worsened hyperandrogenism compared to the normal weight counterparts. So clinical features of obese women with PCO, metabolic abnormalities. So that is also their weight gain and obesity worsen insulin resistance and features of metabolic syndrome. They promote worsening insulin resistance and metabolic dysfunction through the various pathways. So PCOS with obesity will cause anovulation. There are women, all of us know in our clinical practice, who will not get periods unless they have medicines. So it's like a total amenorrhea. You have to give them medicines to have every period. And there are some who will have periods after 3 to 4 months, often prolonged. And then there is a group which will have once in 45 days to 60 days. And sometimes people will not have a clue when they're getting the next period. So menstrual irregularities, anovulation, insulin resistance, impaired glucose tolerance, type 2 diabetes, metabolic syndrome, all of that is PCO with obesity, along with there's a big chunk of cardiovascular events, which include coronary artery disease, OSA, non-alcoholic fatty liver, endometrial cancer in the long run, pregnancy complications in the short run. So fertility issues, reduced incidence of pregnancy, and blunted responsiveness to pharmacological treatments to induce ovulation is common in obese PCO. So often we say letrozole is your first line of ovulation induction treatment in an obese PCO or in a PCO compared to clomiphene, which would be there in the general population. In a prospective study carried out about 158 anovulatory women, dose of clomiphene required to achieve ovulation was positively correlated with body weight. So more body weight, more clomiphene. This is a quite old one. Since then, we have shown common to letrozole, and they have said, and the recent guidelines show that letrozole seems to be the first-line agent. Administration of insulin-sensitizing agents such as metformin also helps to improve menstrual cyclicity in PCO, and that is one of the first-line treatments. In some cases, in adolescents, we start with metformin or non-hormonal medication to try to see whether that does the goal, and if that does it, then you may not go to hormonal medicines. Obesity in PCO, 2270 PCO women receiving clomiphene or gonadotropins, and generally we're seeing that the ovulation rate is maximum when the BMI is lower, and when the BMI is very high, ovulation is of course very low. Obesity and pregnancy, just a few issues here. Overweight and obesity during pregnancy predisposes a woman to gestational diabetes. There's no points in guessing that. Hypertensive disorders, difficult with ultrasound scanning and amnio, because a lot of people, sometimes you have an ultrasound scanning and they'll say not visualized properly due to thick abdominal wall. They don't say the woman is fat, but they say thick abdominal wall, just to subtle, make it sound subtle. And that's one of the reasons to say that this is a lady who you can't see everything what you need to see. Preterm labor, induction of labor, cesarean section, anesthetic complications if a section is done, risk of thromboembolism, all increase exponentially compared to how much of overweight or obese the woman is. Postpartum infection, prolonged hospital stay, all that for the mother, for the baby, also perinatal death, congenital anomalies, shoulder dystocia, some of it related to diabetes, but it may not be related to diabetes also. You can have shoulder dystocia and macrosomia only in big babies, irrespective of a euglycemic status also, and consequently low Apgar, hyperglycemia, hyperbilirubinemia, and NICU. The risk associated with overweight and obesity during pregnancy, just to show that the more normal the women are, the more, if that is the baseline, as it gradually increases, the odds ratio of problems gradually increase. So if it's 440 BMI, then it's a 5-time higher risk of gestational diabetes, 7-time higher risk of hypertensive diseases, then gestational diabetes, 2.5 times higher rate of section, and all that is there. The next part, or one of the last parts, is obesity on fertility treatment and IVF. And obesity on ovulation induction, again, 13 studies, obesity and insulin resistance are predictors of suboptimal outcomes following ovulation induction using gonadotropins. You need a higher BMI, needs a higher dose of FSH to achieve ovulation, and a higher risk of cycle cancellation, and less likely to ovulate in a case of a ART setting. About donor insemination also, if you're using donor sperms, then also depending on the BMI of the woman, the pregnancy rate changes, and the higher the BMI, lower the pregnancy rates is what has been seen. 42% in a normal BMI, half of that in a BMI which is more than that. About ovarian stimulation, the impact of obesity on fertility treatment, gonadotropin requirements are higher in overweight and obese. I think we've already mentioned that. And then IVF outcomes also are suboptimal in a case of overweight. So a lot of people in IVF cycles are asked to reduce weight before they come in for IVF. Of course, easy to say, difficult to do, but at the same time, that is one intervention which, of course, if you tell them that it's in the best interest and it will help her to have more success results, then she will definitely give it a very big try and would like to go for some sort of an intervention for 1 or 2 months before going into the cycle. So all the same thing, gonadotropin things are increased. So here, number of retrieved oocytes at an IVF cycle are just go down with increasing age, of course, but more than that, increasing BMI. So more the age, less the collected oocytes, more the age, or more the BMI, less the oocytes. So everything is going down with age and with BMI. Same for the number of embryos. Female body weight, you see at 24, 26 BMI, just about the maximum. And then as the BMI goes up, the things go down. Live birth weight for overweight and normal pregnancies. Again, it's the same live birth weight. Female body weight. Oh, sorry, I'm going back. So live birth weight and normal weight according to age. Again, same thing, just keeps on showing the same thing, where more the BMI, less the live birth rate. Impact of obesity on ART. So just summarizing most things in one slide, you see the gonadotropin requirement is more, response to stimulation is poor, oocyte numbers are reduced, quality is unchanged, fertilization is decreased, embryo quality is poor, cycle cancellation and OHSS, there's not enough of studies yet, pregnancy rate is reduced, miscarriage rate is increased, and live birth, there's not much study there. So just summarizing in the end, I think obesity on reproductive health has a tremendous impact. Some of it we are seeing in the last 10 years. Some of it we have already guessed before, but we do understand that there are increasing amount of evidence to suggest that weight reduction in a lot of reproductive health issues has enormous value above medication. Again, it is easy to say, difficult to do, but at the same time, it is an integral part of our counseling to talk about lifestyle modification, which will include optimization of weight. There is 95% of people are overweight, which need to be reduced, and 5% of people are underweight, which needs to be increased. So menstruation and menorrhagia, there is an effect. We've already seen that, irregular cycles to prolonged amenorrhea and etc. Fertility, there is a problem to get pregnant by itself. And if you're having a treatment for pregnancy, then there's a problem that you may need more amount of drugs, more amount of medication, more amount of injections. And even after using more, you may have suboptimal results compared to a woman who is of a normal weight. So increased response to clomiphene, letrozole, gonadotropin, and poorer response. So again, it responds, so decreased success rates in all the money you send in IVF fixating. Also increased rate of miscarriage and then later. Thank you very much. I could stop here. Thank you.
Thank you, Doc. Can you hear me? Yeah, Dr. Basop is a lovely personality, and he has discussed such a big topic within 20 minutes. It's a great job he has done. And then obesity is, it's a big problem in Southeast Asia now, because our obesity is different from the Western countries. We have got more organ adiposity, which is actually essentially responsible for all these different types of complications that we have. So as an Indian, I think it is a crisis of civilization. So as a obstetrician and gynecologist or FOXY, we should try to go for preventive measures rather than treating it. So our obstetricians should be more involved in awareness programs, and then I think the problem may be solved. Otherwise, this will be a big problem for us. Anyway, it's a big problem. I'm thankful to Dr. Komal and then other organizers for giving me the chance to share it. All the best. Thank you.
Thank you. Thank you so much.
Thank you, Sandhya. Thank you, Dr. Prananda. Thank you.
Thank you, Basap. Wonderful lecture. And you have covered all the topics. And we are very proud of you representing us in FIGO. So hats off to you, and wonderful AICUG 2023 with nostalgic memories of Bengal, and really a great show by you and the whole Bengal team.
And just in the same words, look forward to a wonderful AICUG 2024 under your leadership, Niranjan, and in Mumbai, and we'll all come and enjoy better. Every AICUG has a flavor of its own, and we love to have your pav bhaji after our rasagullas here.
And of course, vada pav.
Chalo. Thank you.
We will move on now to the panel discussion, and
yes. So I would like to invite the moderators for this panel discussion on near-miss cases in obstetrics. The moderators for this session are Dr. Komal Chavan ma'am. She's a medical director of Chavan Maternity and Nursing Home, senior consultant at VN Desai Hospital, Mumbai, chairperson FOXY Medical Disorders in Pregnancy Committee 2019-22. And the next moderator is Dr. Niranjan Chavan sir. They've both been introduced, so I'm just introducing them in brief. Sir is a professor and unit chief at Lokmanya Tilak Municipal Medical College, commonly known as Sion Hospital. Sir has been the president of MOGS 2022-23 and joint treasurer FOXY 2021-2025. I welcome both the moderators, and I would also like to invite the panelists for this session. The first panelist is Dr. Seema Dwivedi ma'am. She's a National Medical Convener, Indian Thinkers Society, National Coordinator, Maharshi Charak Research and Development Field, Joint Secretary. Welcome, ma'am. The next panelist is, can you just, Dr. Abhasik. Madam is a director, professor, and ex-head Department of Obstetrics and Gynecology at Lady Hardinge Medical College and SSK Hospital, New Delhi. She has held various organizational posts like ex-president AOGD, ex-president NARCHI Education Committee, FOXI chairperson of DAC PCPNDT. She's organized various conferences and has been the vice president of Delhi Gynec Endoscopic Societies. I now call upon the next panelist, Dr. Rohidas Chavan. Sir is a professor and HOD, Department of Obstetrics and Gynecology at Sri Vasantrao Naik Government Medical College, Yavatmal. He has 24 years teaching and clinical experience, and his special interest is in high-risk patients, NDVH. He is the founder secretary of Yavatmal Obstetrics and Gynec Society and has been the past president of this society. Can I have the CV of the next panelist? I now call upon Dr. Archana Kumari. Madam is the present, her present designation is that of an assistant professor in the Department of Obstetrics and Gynecology at All India Institute of Medical Sciences, New Delhi. She has been an associate professor in Gynec department at VMCC and Safdarjung Hospital. She is one gold medalist and has held many organizational posts, which include Joint Secretary, NARCHI Delhi branch. Can I have
would
the
like to add here that she is the first doctor who has delivered the COVID patient in AIMS. So it is on her name that she has delivered, made the protocol under guidance of Dr. Nirja Batla and all the team. So thank you, madam, for joining.
Good evening, sir, and good evening, everyone. It's my honor to be a part of this panel discussion, and I look forward to a very interesting panel discussion now.
Yes. So our next panelist is Dr. Vijay Lakshmi Sheshadri. Madam is a senior consultant, Sundaram Medical Foundation, Chennai. She is the president of OGSSI 2021, past executive member, TNFOG, Constitution Committee member of ISOPAP, and member of FOXI Practical Obstetrics Committee. She has written several publications and has received several awards, one of which is Asia GCC Women Healthcare Leader Award. Welcome, Dr. Vijay Lakshmi. Our next panelist is Dr. Alka Kute. Ma'am has been the president of Amravati OBGY Society in 2008-2009. She is a consultant obstetrician and gynecologist at Amravati. She has done her LLM in criminology and PG diploma in human rights education. She has been the national coordinator for FOXI Ethics and Medical Legal Committee and is been the chairperson of IMA MS Medico Legal Cell. She's been the past president of Indian Medico Legal and Ethics Association and past president of BPNI Maharashtra State. Welcome, ma'am. I now request the moderators to begin with the panel discussion.
Yeah, thank you. Thank you so much. And I welcome all the esteemed panelists today. Near miss cases is a very important topic. It has been introduced in 2016 by WHO. And I have invited, we have invited all the professors of the great medical colleges of India who are the torchbearers in saving mothers and helping in reducing the maternal mortality in the country. Still, it's a long way to go, but I'm sure the efforts which your team is taking has really made India a proud country. And today we are much better off as compared to the other Southeast Asian countries and Latin America, so to say, and of course the African countries. There is still a lot of work to be done, but I'm sure the efforts which you all have taken is amazing. This is the pictorial representation of how a guy has been just missed by a boulder or a box of heavy material just falling besides him, and that's what we do as an obstetrician. I welcome all the esteemed panelists who have been already introduced, doing great efforts, and Dr. Komal Chavan is with me. Presently, she's on another webinar. I'm sure she will join, but in the meantime, we will go ahead and start. Thank you, Dr. Pradnya and Dr. Kanchan Prasad, and the speakers before us, Dr. Giri and Dr. Basab Mukherjee, for an excellent lecture. So in 2016, the World Health Organization defined as maternal near miss case as a woman who nearly died but survived a complication that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy. I remember my head of the department, Dr. Nandanwar sir, we did a trial with ICMR, and at Sion Hospital also, we did this study of near miss case. And I was little confused with the name of near miss. I thought it just missed and the patient has died, but it was not so. Sir explained to me, and I went through the whole process. We have a quasi-judicial body. Every month we appear before them. The maternal mortalities which occur in the Mumbai district are going through a process where I think all of us go through, and we have to submit all the documents, the reason, the post-mortem, and unfortunately we are grilled by a panel of 14 to 15 members who are from different departments, and a thread bearing goes through the whole process as where the mistake occurred. Sion Hospital is in the center of Eastern and Western Express Highway, so we get a lot of transferred and peripheral cases. They are operated outside a cesarean section, or rupture uterus transferred, or a patient with placenta accreta, a previa, an ectopic pregnancy who is in a collapsed state. And then that's how, unfortunately, by the time they come, they're already half gone. And then we need to resuscitate them. But there are very, very lucky people. And there are lucky people because of the presence of you who make the difference to make such cases alive. So I start with the first case. This is a 28-year-old, fourth gravida, with previous deliveries. She was admitted with labor pains at 37.6 weeks of gestation. There was no issues at all. And on arrival, she was vitally stable. The uterus was full term, irritable, cephalic presentation. Fetal heart sounds were 140 beats per minute. And on per vaginal examination, cervix was 3 centimeter dilated, 30% effaced vertex, membranes were present. The hematological investigation were normal and there was nothing to worry. But after 5 minutes, when the spontaneous rupture of membranes occurred, and during a large contraction, a large gush of amniotic fluid came from the vagina, the woman reported an urge to push. Suddenly she became disoriented, confused, and she could not breathe. She was totally, absolutely under some influence, little bluish in color, and she collapsed. On examination, she was unconscious, non-responsive. The pulse rate was 120 per minute, blood pressure 90/50, SpO2 96. Immediately we called up the anesthetist. The respiratory rate was 20 per minute. Heart sounds were present, but she had tachycardia and there were crepitations. I would request Dr. Seema Dwivedi to please have a likely diagnosis or a differential diagnosis. If she is there now. Yes, madam.
A very good evening to all. Now we here have a patient who has shortness of breath with difficulty in breathing, sudden drop in blood pressure, pulmonary edema with Krebs, abnormal heart rate, and agitation, confusion, and sudden anxiety. So this clinical scenario fits very well in a case of amniotic fluid embolism as it usually manifests. And shortly after labor. So, and most likely the combination is that of very intense uterine contractions along with the amniotic fluid, whether it be it passage or even in cesarean section when we have suddenly, we have opened the uterus and with the sudden gush, this may be a possibility. And that is why we always tell our residents to kindly take care to keep your fingers towards the apex of the incision which we have given, so that we prevent it. Although it's a rare possibility, but then this is the most in this such a young patient, this is most common probability. And the differential diagnosis are the most common differential is pulmonary embolism, besides myocardial infarction and vasovagal. And the Society of Maternal Fetal Medicine and the Amniotic Fluid Embolism Foundation have recently proposed 4 diagnostic criteria for amniotic fluid embolism. The first one is sudden cardiac arrest or both respiratory and hemodynamic collapse, and biological disseminated intravascular coagulopathy with absence of fever and clinical onset during labor or within 30 minutes of delivery. So the scenario is fitting that of amniotic fluid embolism, though we do have to exclude the other differentials also.
Thank you, madam. Such are very rare cases, and in my 30 to 32 years of practice from as a resident, I have seen only 1 or 2 cases. It's a very rare and very lethal.
High mortality.
Very high
Very high.
mortality.
Very
And
high.
I've seen that they have just gone up within 2 minutes, 1 to 2 minutes. I mean, it's a very sad situation. And as you have said, there are various criterias which have been there. I would like to move on now, madam. Professor Abha Singh, thank you for joining. How would you manage this patient? It's a very a situation where you have the differential diagnosis, but now how you can go ahead? Sudden, you call for help or you go ahead and do resuscitation, madam? Well, if Dr. Abha Singh is not there, Dr. Seema, you can continue in the meantime.
So we had such a case, forceps was applied and suddenly she collapsed immediately after application of the forceps, and the whole team was confused whether she had developed some hematoma inside the intra-abdomen or whether she had gone in shock. But we could diagnose her as she started developing cyanosis. She had there was great sweating. She started developing cyanosis, and the blood which was withdrawn was absolutely black, very much deoxygenated blood. So very typical of amniotic fluid embolism, and it's as I told, the mortality is very high. But if the team is there, it is a multidisciplinary approach. Immediately we call the anesthetist. The central line was put in, and she was immediately managed, intubated, and all immediate resuscitation started taking place because she had delivered. So we were at least assured regarding the baby, but the mother was taken care of. Finally, she developed DIC. Even that was taken care of. So in my life, of the 3 patients which I had seen, only this which we could save because anesthetists were immediately available. So highly intensive care is needed in this patient with the help of an anesthetist and with the ICU available nearby. So in BHU, where I was resident, ICU was immediately available nearby our department. So we could manage and salvage and save this patient. Otherwise, by the rest of the 2 patients, we could not save. They were lost.
Yes.
Dr. Chavan, am I visible now?
Thank you, madam, for joining. I thought
Dr. Chavan, am I visible now?
Yes, madam. Yes, please go ahead. The question is for you. Please suggest your management, and we can hear you. And of course, the experience which you have from Safdarjung Hospital. Dr. Abha Singh, we can hear you. If you are there, please go ahead. Well, amniotic fluid embolism, it's a catastrophic condition that occurs during labor or within 13 minutes of postpartum. It's 1 to 12 cases per 1 lakh deliveries and often lethal, as I said before. It's poorly understood. I remember reading Williams Obstetrics. There is a big 2-3 pages on amniotic fluid. It is so confusing, but the sudden gush of
Dr. Chavan, am I audible and visible now?
Yes, you are audible as well as visible, madam, and we can hear you clear and loud. Please go ahead.
Thank you. Because at that time you said I was there, you said I'm not there. So I said, no, I'm there. So I don't know what happened. How I disappeared.
Madam, we cannot, as I'm showing the screen, I am not able to see the
No, it's okay.
participant-
Then you can be, I can be heard. Huh? That is the thing.
Yes, no, I cannot see the participants. That's the reason I was telling, but
Okay.
now I am able to see you. Please go ahead.
Okay. So one thing is, you rightly mentioned amniotic fluid embolism. Amniotic fluid embolism is really a catastrophic condition, and it is usually seen immediately after delivery or maybe up to 30 minutes after in the postpartum period. And what happens? There is a sudden compression of the uterus. There's a strong contraction. There's the compression of the uterus, and when the liquor escapes, some liquor enters the sinuses, and through the sinuses, the meconium, the fetal squamous, and the vernix, all these things, they enter the blood circulation. And this causes a state of anaphylaxis, which leads to all these problems. There is a sudden drop in the blood pressure, and there is a status like a DIC, biological DIC. And then what happens? There is respiratory problem, there is cyanosis, the blood pressure, it reduces immediately, and the pulse rate, it is really very fast. But only thing is, the patient does not develop temperature. So that is a thing which is in favor of amniotic fluid embolism. It is not a septic embolism. And detection has to be done just immediately like that. You don't have time to wait. So first thing is, maintain an IV line. Fluids have to be given. Anesthetist has to be summoned immediately, and then resuscitation of the patient has to be done till the anesthetist arrives. You can do it on your own, and try to deliver the baby as soon as possible. If the cervix is dilated, you can deliver her by applying a ventouse or applying a forceps, or if required, you can even do a perimortem, sort of a cesarean section. And then blood samples have to be sent for labeling her as a case of DIC. You can see the levels of the blood sample, but you cannot wait for that. So this is the basic and a multidisciplinary approach. As you already said, ICU management by anesthetist. You can call the physician, you can call the hematologist. So all those things will be required. And blood products have to be asked for. And this is basically, and usually the diagnosis is made post-mortem, when you do the post-mortem and you see the fetal forms and everything in the blood vessels. So
it's an unfortunate thing which can occur. It should not happen with any obstetrician, but I'm sure there are few of them who have been saved, and this was one of them. She was on ventilator for about 10 days. She came out and obviously then recovered back and went home with a neurological deficit. She's been
neurological deficit, heart damage, then complications from stroke, kidney problem, anxiety and depression, and post trauma stress. So all these things deficit are common if the patient survives.
Yes, madam. Thank you so much. And
can I add one sentence? Can I add one sentence?
Yes, Dr. Alka, we will come back to you. Just be quick, please.
One line of
We have got
sentence.
5 cases and I need to finish on time.
Okay.
Yes, madam, please go ahead.
Yeah, only one sentence. When the body is sent for postmortem, we have to write that there is a possibility of amniotic fluid embolism, so that the postmortem person will see what are the amniotic fluid debris and etc. Then we don't just write for maternal death review or like analysis. So it's not sufficient. So we must write amniotic fluid embolism as a cause we are suspecting. So the postmortem doctor will see accordingly, and it will support our defense if the patient's relative go into court of law. That's all.
Madam, we are discussing today near miss case, and we do not want to discuss any death here.
Naturally.
And of course, no PM here. That is a different panel discussion which we will have, medical legal or maybe on other subjects. So thank you. These are the references. Mothers hold their child's hand for a moment and they are hard for a lifetime. We move on to the next case. A 32-year-old woman was referred to our hospital from periphery following a vaginal delivery at 39 weeks period of gestation, and the pregnancy and labor went uneventful. Placenta was delivered, controlled by controlled cord traction. Following delivery, woman was discharged. And after 24 hours, 48 hours, she was fine. And then she had, a certain amount of abdominal pain with heavy vaginal bleeding. She reported back again after 48 hours. She had blood soaked in her clothes, large clots of the size of her fist, and she was dizzy on standing. This was the situation when she arrived at the labor ward. On examination, she was drowsy, she was pale, cold, and clammy extremities. That means she was in shock. BP was on a lower side, 190/60. Respiratory system was clear, but the pulse rate was severely tachycardia. She had tenderness on the uterus, abdomen, and the uterus was, palpable, which was just above involuting. And on per speculum examination, there were large blood clots, os was open, episiotomy site was intact, there was no further bleeding from any other site. Her hemoglobin was 5.8 and WBC count was 23,000. Coagulation profile was normal, and I have not mentioned the per vaginal examination, but Dr. Rohidas Savant, Professor, HOD in Yavatmal Hospital, has seen such cases. I would like your opinion. What would be the diagnosis in such cases?
Yes, sir. Am I audible?
Yes, everyone is audible today.
Yeah, okay. Thank
Everyone
you
is
for
audible.
Yeah. Thank you for including me in panel discussion. Basically about the case you have talk about the case scenario. She is a post-delivery patient. After 2 days, she passed big clot and came into shock. That is basically secondary PPH, and it is included in hypovolumic shock. So with blood transfusion, other uterotonics, other management, patient can be saved. But my suggestion is that
Dr. Rohidas Savant.
Yes, sir.
Would you like to mention and do a per vaginal examination, which I have not said? That is very important before you.
Yeah, definitely the past clot and his normal delivery case, definitely basic examination should be done. That is pulse, BP, abdominal, uterus, whether it's contracted per speculum, any tear or any like that, any hematoma, that things be checked. But after checking all these things, basically she developed a hypovolumic sort of picture.
Yes.
In that patient, basic to bring her BP up by giving the crystallized bloods immediately and with antibiotic, anticoagulants, patient can be saved time being. But in such patients, usually
Sir, your impression is it retained products of conception, placental bits which are retained? Some infection. There is no foul smelling discharge. There is no hot vagina, though she has a tachycardia. And absolutely right, you said that she has hypotension, cold clammy feet. She is in shock.
It is basically
blood crystalloids because her hemoglobin is 5.8. Otherwise, if you do not treat her, she will go in DIC.
Her basically diagnosis secondary PPH. That is, she started bleeding after 12 hours. So according to that, management can be done.
Yes.
So what is the cause of the secondary PPH? What is the likely cause?
Secondary PPH, madam, actually immediate after delivery, how do we monitor like 4th stage of labor? During that time, it should be confirmed that nothing is remain inside.
So basically, it is the retained bits of placenta
whether the whole placenta was removed or bit of the placenta was left
Yes.
inside.
No,
So
there
that
can be an
is
accessory lobe of placenta which gets
accessory
sometimes
lobe
missed.
also, yes.
And that is the reason we need to check if the placenta is intact. So I think we can move ahead with the management. Dr. Archana Kumari.
Yeah, good evening, ma'am. Good evening. So for the management per se, as the patient is already in hypovolemic shock, we need to do immediate resuscitation of the patient. And for immediate resuscitation, we need to restore the blood volume that has already been lost. And along with that, we have to increase the oxygen carrying capacity of the blood. So for resuscitation, we need to transfuse crystalloids. Around 2 liters of warm crystalloid has to be started, and meanwhile we have to insert 2 wide bore IV cannulas so that blood fluids
What
can
is
flush
the
it immediately.
what is the gauge of the cannula? 18 number, 16 number,
14 gauge wide bore IV
14
cannula.
gauge. So delegates, please remember 14 to 16 gauge. Call for help.
Yeah,
It's
and
very
the call for
important.
help has to be done. 14
Yes.
gauge cannula has to be inserted, and immediately after starting fluid from 1, we can take blood, 20 ml blood for her baseline blood parameters, and we will
I think yes, and the oxygen head low. It's very
Yeah.
important. Head
I'm
low.
coming
I
to it.
remember in my days, we used
Yeah.
to put half block, full block.
Yeah, we'll make the patient lie down on a flat surface and keep her in some warm cloth, some kambal and all, and we'll start her on high flow oxygen, 10 to 15 liters per minute, and we'll take 20 ml of blood for blood grouping and cross matching along with other baseline
Other
parameters.
investigations.
Okay, and
Madam,
after
20
that,
ml बहुत ज़्यादा होता है, madam.
बहुत ज्यादा है.
it is
बहुत
recommended.
ज़्यादा है.
अरे 10 ml बहुत है.
Yeah.
बहुत है.
Okay, after that, what we do is after that, we send the requisition for blood and blood products, and after that, till the blood is available, if 2 liters of fluids has already been transfused and yet the blood has not come, we can even give IV colloids to replenish the blood volume.
We do start Himaxil and crystalloid. That's what is one side. And I remember there are in such situations, you have to wear gloves yourself and
Yeah.
start pushing blood. Push.
Exactly.
Push.
And along with that, we will see do the pervaginal examination and see whether there is any retained blood product, retained bits of placenta or any retained clots are present or not. Then we try to evacuate it digitally, and in order to stop the bleeding, we also give uterotonics, like we can start her on oxytocin 20 unit in 500 ml of normal saline, or we can give her misoprostol 800 microgram, which is available everywhere. So meanwhile, by giving uterotonics, by starting with the bimanual massage of the uterus, we try to remove any content which are present in the uterus.
If I may add here, we have used the AV retractor after holding the.
This is the problem. You people use AV retractors and people say this is the instrument to do DNC.
No, I will tell you, instrument for DNC. The cervix is wide open.
We have used sponge holder for holding. Just listen to me, madam. We have used sponge holder for holding the dilated cervix. Put the AV retractor. Why? Because the curettes are very sharp. The Blake's curette is very sharp, and it is very small. This uterus is 24 week size, such a big, huge uterus. And that gentle curette from the AV retractor with the blunt, it doesn't hurt anywhere. It will not perforate. There's nothing to worry. You just need to scrape out at the cornu or at the accessory lobe. And I've seen miracles happening.
Yeah, so after having expedited the process of removal of any bits, we will also start her on IV antibiotics, and also do it to catheterize the patient to monitor her input-output, so that we can be aware whether what is the amount of blood loss that it has been adequately.
The reason for catheterization, if I'm sorry, I'm interrupting. Of course, you're all professors, but that bladder which is full is a detrimental for uterine contractions, and you need the uterus to contract. And if the bladder is full, it will not allow it to contract. So you need to deflate the bladder. That's the reason you need to catheterize. And the second thing is that when you catheterize, you will also come to know the urine color. Whether it is high colored, that means she is dehydrated. It is frank blood, that means there is rupture. You have to think a lot of
gone into DIC.
Yes, and DIC, yes.
Patient is gone.
Yeah, yes, sir. Yes, I fully agree with you. And after having stabilized the patient, we can shift the patient according to her vitals into a ICU or into a HDU. So in ICU, we'll do continuous monitoring of the patient. And in HDU also, we'll do the continuous monitoring of the patient, her pulse rate, the blood pressure, the vitals, and we'll transfuse her blood and blood products according to whatever has been the loss and according to her hemoglobin.
Madam, the magic has worked. In the next 10 minutes, she's alive and she's going to be back in the ICU and going home. That is what you have done. And we are really thankful for all the efforts. Use stockings, use heparin. Is there any role of ultrasound? Dr. Vijaya Lakshmi, if she's there.
Yeah, good evening.
Good evening,
Thank you,
madam. How are
thank
you?
you, Komal and Niranjan. I'm still in theatre, so I just logged in from
Madam,
here.
what are you operating today?
I had bilateral ovarian torsion.
Oh.
Bilateral.
So God just
Bilateral.
stuck. Yeah, and then
Very
anyway,
rare.
did it operation is
Unilateral is
okay.
common.
So you see the dedication of our panelists. We are so proud of you, madam, that you are still there with us. In the
Yeah, sure.
operation.
It's a pleasure always to join you. As
Yes.
far as your question goes, whether there is a role of ultrasound, I think clinical scenario comes first and our diagnosis goes good. But at the same time, we do definitely do ultrasound in our practice a little bit. But of course, there is a lot of confusion because when we do ultrasound, we know there is a big uterus hanging on there postpartum and then with full of blood inside. And therefore, it might confuse our overlap with the uterine retained products as well. But at the same time, I think one ultrasound we definitely do just to while we are also attempting to evacuate the uterus and all those steps which the previous panelist has said. But at the same time, ultrasound we do.
Sorry to
Yeah.
interrupt. Ma'am.
Yeah,
But
yeah.
if you have an ultrasound in the labor room or the labor ward, utilize the services if you are having any doubt.
Yeah.
But the literature says ultrasound
not required
is not indicated. So do
Yeah,
not
no,
wait
may
for an
not be required.
ultrasonologist.
It's a clinical discussion.
Clinical
which the-
presentation is very important. Retained products of conception is there. Dr.
but
Archana
yeah,
Kumari
but-
has
but
really
we
has
do
done a
use-
wonderful job, and Vijaya madam is still there around. It's just a clinical impression, and that makes a difference. Yes,
Dr.
ma'am.
Niranjan, can I ask you one thing? Role of
Madam,
panic
please
noise
do not ask me
suction.
any questions. Madam, you are the boss.
No, panical suction, that one.
SR cannula. SR cannula will
yeah.
not come now. It will come in PPH. You need to remove the cause. If you do not remove the cause, those bits of placenta, how are they going to come from those small openings? If you have a clean cut PPH, well, that is a modality.
Atonic PPH.
One of them you can utilize. But we cannot blanketly say that, yes, you go ahead, because there is a balloon which you can inflate. Barclay's balloon is there. There are so many modalities which are available. Chow sutures, Hay sutures, balloon, and so on and so forth. So that is a very different perspective. We will not go and dwell into that. But I'm sure ultrasound scan do not run
But
after.
Niranjan, sometimes when we do a little bit of suction, a few bits of membranes come on, and then you can hold on and clear the uterus as well.
Yes, so now
that
we have an
definitely
experience.
helps.
Yes, from South India, we have Dr. Sheshadri, and she recommends that, yes, at the end of the procedure, you can surely utilize that cannula and go ahead, and it is going to suck out everything, whatever is there, and it's going to be helpful. Thank you, madam. So these are the references which are there, been given to us. We go
Sir,
ahead.
can I add one more point on whether
Yes,
we
yes,
should do
yes,
ultrasound
Archana.
or not? So
Before you add, I want to say something. A mother's arms are made of tenderness, and the children sleep soundly in them.
Yes, sir, very true.
Oh,
very
lovely.
true. Yes, sir.
Isn't it? You are so happy to see the mother back with the baby in their arms.
Yes.
Archana ji, please go ahead. Thank
Yes,
you.
sir, regarding whether we should do ultrasound in patients with secondary PPH or not. For special scenarios, when the patient comes with recurrent bouts of secondary PPH, then we should go for an ultrasound along with Doppler to rule out rare causes like arteriovenous malformations.
Yes, I agree with you.
Had several cases where the patients comes after being referred from several centers after repeated curettage, but still the patient bleeds because they have had AVMs which were not diagnosed.
We have seen in gynec cases and they have been readmitted again and again. They come back and where we can take the help of, once confirmed, we can plug that AV malformation with the help of the interventional radiologist department and affordability of that patient. But I'm sure DNC will not help in such situations. You have to be very careful. Unnecessarily, you will cause more amount of bleeding.
More hemorrhage.
Yes, and infection and more again and again. So you need to have a proper diagnosis. But at that moment, when you have such a patient in a collapse state and she has come back to you within 48 hours, you need to think that there is something wrong in her uterus. And that's how you are going to manage. Thank you, Dr. Seshadri. Thank you, Dr. Archana and Seema ma'am. We go to the case number 3. Dr. Komal, would you like to?
Yes. Yeah. Now we have here a 42-year-old, gravida 3, para 2, living 2, 34 weeks gestation. She's a previous 2 cesarean and she comes with breathlessness since 3 days. ANC period looks okay. The ultrasound is normal. The blood pressure in the ANC period also was maintained. Now there is shortness of breath and it is worsened. Left-sided chest pain on breathing. And on examination, she's conscious, well-oriented, pulse, tachycardia as we see. Blood pressure 130/80. Next slide. And CVS, there is a systolic murmur. The RS clear. Left leg, there is an edema. Uterus 34 weeks, cephalic. FH is 144 beats per minute. Per vaginal os close. She's not in labor. And an urgent ECG was done because she came and ECG showed sinus tachycardia with S1 Q3 T3 pattern and ABG done. So suggestive of respiratory alkalosis. Next slide. So Dr. Alka Kuthe, so when we get like this patient, what is your diagnosis based on the history and the investigation?
Yeah. Actually, she is 42 years, third gravida with previous to LSCS at 34 weeks. And she has developed these symptoms suddenly without any ANC problematic, means any pathology in ANC period. I think there is some acute respiratory problem. Most probably it can be related to her, maybe because of some silent rupture cases there, except respiratory distress and respiratory alkalosis, along with tachycardia and respiratory rate is tachypneic is there. I think there can be some embolism, respiratory embolism, pulmonary embolism, maybe because secondary to rupture, that's silent rupture. And second thing, it can be because of age-related problem. She's 42 years old. There can be some cardiac problem. It was not diagnosed previously, but for the first time it is presenting during her this 34 stage. So there can be differential diagnosis of pulmonary embolism and with some pleuritic element, maybe because of secondary to heart stresses, like we say cardiac problem primary, secondary to that because of her age factor. And mainly it can be pulmonary because it is acute episode and suddenly she has developed breathless. There was nothing else in antenatal period. So I will label it as a pulmonary embolism case. And of course, we know due to her age factor, she is previous to LSAs, bad patient. At 34 weeks, she develops such respiratory distress. She's a bad patient for further, the prognosis is very bad, but we have to save the life of the patient because it is near maternals.
Yes. Yes, rightly said, pulmonary embolism is a most fatal illness when it comes to pregnancy, and it is due to obstruction of the pulmonary artery or in any of its branches by a thrombus or some air or fat or anything which gets lodged into it. And the presenting complaint like shortness of breath, sharp pain in the chest, will be very prominent with cough or there would be bloody mucus. So these are the frothy mucus, what we say in pulmonary embolism. And these patients will come everything would be so sudden onset and they require immediate diagnosis and immediate care in a tertiary center. So the next slide, I would ask Professor Seema Dwivedi Now, how do we further further imaging? What would be required for the diagnosis?
As ma'am, as the differentials may be that she is having shortness of breath, the differentials may be an underlying cardiac problem. And in amniotic fluid embolism also we had seen that she develops respiratory distress, and this may be a possibility of pulmonary embolism. So we need to have a proper imaging lineup in which pulmonary embolism is confirmed by CT pulmonary angiography showing an intraluminal filling defect, or helical CT, even that will show an intraluminal filling defect in a lobar or main pulmonary artery. And a ventilation perfusion scan, which is showing a high probability. And if the diagnostic test, especially the ultrasound color Doppler of the venous legs veins, which reveal acute DVT, even if it is a non-diagnostic ventilation perfusion scan or helical CT, even if they are inconclusive, because if the embolism is in the smaller arteries, we may miss if the major arteries are not involved, as may be in this case. So in that case, if there is a DVT in the venous vessels of the legs, that is highly probable. But if the D dimers are normal, pulmonary angiograms are normal, perfusion scan is normal, and normal proximal venous ultrasound, then pulmonary embolism is excluded if all these findings are normal.
Yes. So that is so right, that we really need to resort to imaging, and we need to keep the role of CT pulmonary angiography in this case. Dr. Abha Singh, how would you manage now? Because management is really a dilemma. We know that we are really into a catch situation where we are scared about an unforeseen mortality, and how and the patient is not delivered. So what would be your take on management?
So one thing is we can do some investigations like D-dimer test. If it is increased, again it is quite confirmatory. And then BPN you can do PNP, that is brain natriuretic peptide. That will also tell you whether there is some injury to the heart, blood is not going there. Then you can do troponin test also. So all those things can lead to a diagnosis. Then once you have thought that these things can be there, you send the blood for coagulation studies, D-dimer test and all those things. And in the meantime, you can start the patient on anticoagulant.
Yes.
The mainstay of treatment is you can start low dose heparin, or you can even start enoxaparin, but heparin is the main drug which you can start. Around 15,000 international units can be started subcutaneously, and low molecular weight heparin, I was saying 15,000 units subcutaneously can be started, and this has to be given for at least 3 days. In the meantime, leg elevation, you can put magnesium sulfate lotion around the leg, and elevation of the leg, and it has to, and after that, after 2-3 days, you have to maintain the INR to 2.5 to 3 times of normal, and then after 2-3 days you can start warfarin. Warfarin is oral, so you can start that also, but then you have to overlap with heparin for at least 3 days. So once the patient has delivered, you can give warfarin, but only thing is breastfeeding should not be done, because this warfarin is going to the mother's milk.
Definitely,
so all these things have to be taken into account. And if you have not delivered the patient earlier, you've started heparin, then you have to stop heparin 12 hours before the delivery, so that the chances of PPH are minimized.
Yes, very, very nicely summed everything. And we need to really, the mainstay of the treatment is stabilization of the maternal condition. Here we know the patient has come pregnant, but we need to stabilize. That is very important. And so well you have pointed out how to go about with the coagulation therapy, when to start warfarin, when to stop heparin, and how to do after delivery, what precautions to be taken. So we really, really want the patient to get stabilized post-delivery, and anticoagulation can be continued from to 6 weeks to almost 3 months post-delivery. And there are some studies also where say that warfarin can be given. You can counsel the patient and can give even with breastfeeding. And but compression stockings needs to be given to this patient because we don't want this patient to have long-term morbidity. So next slide.
And these patients are more prone to develop the same problem in next pregnancy.
Yes. So they keep getting, and definitely we really don't want these patients to get pregnant again. So counsel them, tell them, you know, we need to now be, and she's 42 years old. So hopefully we should keep our fingers crossed she doesn't come again. So next case. So life of a mother is the life of a child. You are two blossoms on a single branch, and that is so true. So moving on, we have here a 29-year-old primary gravida woman noted to be at the 39th week of gestation, and she comes to the hospital complaining of significant shortness of breath. On examination, pulse is 120, respiratory rate is 32, labored breathing, oxygen saturation is 85. And when she comes with such dyspnea and the saturation being low, suddenly a chest X-ray has been advised, and it reveals bilateral pulmonary infiltrate and enlarged cardiac silhouette. And seeing this picture, what comes into your mind, Professor Seema Dwivedi?
Hello. Ma'am, as one after another, we are discussing all the patients with shortness of breath. And first we had amniotic fluid embolism. Second, we have pulmonary embolism. And now here we are suspecting peripartum cardiomyopathy because of the dilated heart, which we are seeing in the X-ray picture. And in the X-ray picture in pulmonary embolism, we get an enlarged pulmonary artery, and that is referred to as Fleischer sign. But here we are getting, because peripartum cardiomyopathy is idiopathic heart failure in the absence of any determinable heart disease, and is characterized by its rapid clinical course. Yes. And the diagnosis are the 4 criteria, that is the development of heart failure in last month of pregnancy or 5 months postpartum, absence of any pre-existing heart disease, and the cause is not determined. Besides the echocardiographic findings, they will show left ventricular end diastolic dimension of more than 2.7 centimeters per meter square, M mode fractional shortening less than 30%, and left ventricular ejection fraction less than 45%. So basically, in a young patient who doesn't have any other probable cause of cardiac involvement, and on X-ray or on echocardiographic findings, we are getting a heart which is failing and is not working properly. So the possibility of peripartum, which again is very rare, is definitely there. And most likely environmental and genetic factors are there, and some viral etiology is also implicated, leading to myocarditis.
Yes, I think rightly you have pointed out the apt diagnosis that it is a complaint which is seen in absolutely normal patients. So criteria is that we need to know that the patient is good following, had no history of any heart disease or anything. And when we check we happen to the onset of the shortness of breath and everything happened near term. That are the criteria, and this is how the 2D echo is the diagnostic picture which is seen in peripartum cardiomyopathy. So an X-ray which was done, I think this is a very good tool. If a patient comes in emergency, if we don't have a 2D echo handy, we all have an X-ray. Advising a simple X-ray, you know, in 3rd trimester, it is quite safe. And even in a postpartum patient, when we see this peripartum cardiomyopathy, we really can do a simple X-ray. It actually tells us so much knowledge that we are dealing with peripartum cardiomyopathy. So coming to the next question to Dr. Vijay Lakshmi. Next question. Next slide. Yeah. So what is the mechanism for this patient's symptoms? You know, ideally this is all becoming, I think, little Dr.
Basically
has also spoken. So I just want you to complete it.
No, basically, as you have already explained, this can happen suddenly. I mean, even without known predisposing factor ahead, or sometimes even in patients who have some cardiac problem. In fact, just I would like to mention here in our government hospitals in Chennai, we do have, I think whole of Tamil Nadu, they have brought in a system where every pregnant patient in government hospitals, every pregnant patient goes through one cardiac evaluation and ECG. Of course, we know that it may still not be able to predict the cardiomyopathy, because this can happen close to term 1 month before or 5 months later also after delivery. But still, just at least to avoid or pick up some predisposing factor, they have done it, because again the mortality is so high, and it's really our responsibility to save these patients. So that is one scenario which I just wanted to put in. But actually, if you see here, what is happening is dilated. It's a kind of a dilated cardiomyopathy or hypertrophic also, but the whole heart becomes weak. In a very simple term, the contraction of the myometrium goes down, and that triggers then the sequence of events, and therefore that is why we have these dilated hearts. If you see the muscles and all, they are really thinned out, and all those sequential pictures starts from here. And it can definitely present suddenly, unless we have a very suspicious mind to think about this diagnosis. We may not be able to save the patient, and that is very important. And it all starts with the reduced muscle power of the heart. The cardiac contractility comes down, and that is where it gives like a flabby balloon, which, ball just keeps beating, and that is where the efficacy comes down, the ejection fraction comes down, and then all those sequences of events go on.
Yes, and the most important, now we know a probable diagnosis, and now coming to the management, Dr. Abha, because management is the key. We need to manage it very judiciously and very multidisciplinary approach. So I think Dr. Abha, you can speak on that.
So, the thing is, postpartum cardiomyopathy is a really serious condition. So we have to have a multidisciplinary approach. First of all, anesthetist. Second, we can have say
cardiologist, yeah,
and then we can give her ACE inhibitors. Earlier, we used to give all these things. Nowadays, beta blockers and diuretics. These are the main anchor of the treatment. Nowadays, they are giving bromocriptine. And bromocriptine has been found, it is given according to dose adjustment, and around 20 milligram per day for 8 weeks. So this bromocriptine has been shown to have good result.
Yes, I think first we need to deliver, because bromocriptine probably we can consider starting post delivery. After delivery. So we need to first stabilize, giving diuretics, digoxin, and because it is related to pregnancy, I think even the delivery would be a good option here, and stabilize the patient. And bromocriptine is upcoming. There are many studies favoring the use of bromocriptine. And we definitely have spoken about the pathology of peripartum cardiomyopathy. So I'll not go next slide. And what is most important, I think this all we have spoken, the clinical presentation. Next slide. And what I want to add about the bromocriptine, I think that is very important, and we need to continue the bromocriptine therapy also, because these patients, they have the history of heart failure also later on, and their ejection fraction needs to be monitored, because they really need to be keeping it, because the ejection fraction goes below 30, it becomes very critical. So we need to even advise them not to get pregnant again. And to get pregnant also, we require the ejection fraction to come more than around 50, 45 to 50. And bromocriptine therapy does help in these patients for maintaining that period, the stable period. And there are so many studies which are done, in German studies are there, showing the role of bromocriptine in a long-term follow-up, and where the ejection fraction has returned back to normal. So I think Dr. Abha was highlighting the same. Anything you want to add?
No, it's okay. There is a newer drug which earlier we used to give for some other indication. Now this indication has been taken up, and the results have been found to be quite good, and it has to be given for a prolonged period for at least 8 weeks, and the dose has to be adjusted according to the problem of the patient. So
Yes.
that is what is there. And yes, I forgot to say that yes, the patient has to be delivered first before
Yes.
starting.
Yes, that is there. So a mother is she who can take the place of all others, but whose place one can, but no one can take. So that is so true. We really require, and all our patients, we don't want to near miss any mother. So that is what, and I hand over to Dr. Niranjan Chavan.
Thank you, Dr. Komal. And we move ahead to the case number 5. 34-year-old, Gravida 4, Para 3, living 2, abortion 1 with 2 previous LSCS. 39 weeks period of gestation, came with severe pain in the abdomen. She was drowsy, disoriented, 140 beats per minute, pulse rate, blood pressure 190/60, per abdomen tender, fetal parts palpable. Now this I have given way. I am sure everyone knows what is the diagnosis. The fetal heart sounds could not be localized. Hemoglobin 6.8, rest of the parameters, coagulation profile being normal. What comes in the mind?
Uterine rupture.
Rupture of
Yes,
uterus.
uterine rupture.
Nothing else.
Nothing else. And this is a very clear cut. And if you put your finger inside, I remember when we were as a resident or as a lecturer, assistant professor, also now, when we have to be called, I was called today afternoon. In the OPD, I got a call that there is something uterine rupture. So I said, okay, fine, I'll come there. And I went after some 15-20 minutes. And she had a scar rupture. And they had already sutured. But what had happened was that because of the 2 previous LSCS, the bladder had advanced. And as a result, they were finding it difficult. And there was also extension of the left uterine artery going downwards. So we need to go through the apex, suture it, and I had to wash up and help and assist my assistant professor. Such situations come. Luckily, this patient's uterus got saved, but unfortunately, this patient had to undergo an obstetric hysterectomy. 5 units of PRC were given. Her hemoglobin was then come up with all the blood transfusions been given. She was relatively stable, shifted. Now, after 2 hours, patient suddenly collapsed. Dr. Rohidas Chavan.
Yeah.
Now you are called.
Yeah.
What is it?
Immediately after 2 hours, she collapsed.
Yes.
Sometimes sudden response, that is some inflammatory response, which may cause shock due to release of cytokine. Sort of picture is there.
Yes. Yes. Sudden inflammatory response, massive cytokine release with shock. Never leave your obstetric hysterectomy case. Just done, everything over. Patient is extubated. She shifted to ICU. You're all having some meal, chit chat, very happy. Everything is good. But please remember, such situation can come. How do you prevent it, Dr. Archana Kumari from AIMS?
Sir, you have already
Premier
mentioned that we
Institute.
have not, sir, you have already answered the question. You said that we don't have to leave the patient on the anesthetist and we have to take care of the patients immediately in the post-hysterectomy phase and do the continuous monitoring of the patient, including her blood pressure, the respiratory rate, her pulse rate, her urine output, her abdominal GERD charting, and all this has to be done meticulously in the ICU, so that any compromise of the mother has to be identified at the least warning and be promptly managed.
It's very important, very important. And unfortunately, some patients have really gone into irreversible DIC and they had to be re-explored because of hemorrhage in the abdomen. And it becomes a whole messy situation because when you go on for a re-exploration, and she's oozing from everywhere. She's oozing from the stumps. She's oozing from even the veins. Even the blood pressure is quite okay, 100, 110. She's on adrenaline, noradrenaline support. But remember, it's very important to give correct and appropriate, urgent, appropriate, massive blood transfusion to reduce all this catastrophic event. Her urine should change. Her urine color should change over a period of time. Never give Lasix in such situation, because she will go further in hypotension, and that will reduce the blood supply to her brain. So it's vigilant monitoring. Do not have a lacucidal attitude. Do not be complacent. You have answered very well. Immediate resuscitation. Uterine rupture. Can you talk something on uterine rupture, Archana madam?
Yes, sir. Yes, sir. So uterine rupture is actually a very important cause of postpartum hemorrhage in today's scenario because of the increasing rate of cesarean section. And it can be either complete uterine rupture or it can be uterine dehiscence when the serosa is still, the amniotic membrane is still covering the baby inside. So for diagnosis, for prevention of uterine rupture, actually we need to have continuous, we need to have proper selection of the patients before we administer the VBAC to the patients of previous cesarean. So we have to know of the factors which increase the risk of rupture, like if there is short interdelivery interval, like less than 12 months before the, in the last pregnancy was before 12 months, just 12 months before. And if there is thin uterine scar, the scar thickness is less. And in patients who are more than 40 years of age, these are some of the factors which increase the risk of rupture. The type of cesarean scar which she had retained in the previous pregnancy, like was it classical cesarean? Was there any previous history of rupture of the uterus? Was there opening of the uterine cavity during previous myomectomy? So we need to have examine the patient holistically and do proper selection of the patients before administering VBAC to the patients. This is the first thing. And the second thing is that we need to do continuous monitoring of the patients in established labor. We have to give one-to-one care to the patients. We have to have IV access on. We have to have the blood arranged. We have to do continuous fetal monitoring of the babies. And we have to do regular monitoring of the maternal and sign and symptoms, and do the 4-hourly assessment of progress of labor to find out if there is any labor dystocia or if there is any maternal or fetal compromise, then do immediately cesarean section. Thirdly, I would like to point out that if the patients of previous cesarean sections are induced or they are given augmentation of labor, then this increases the risk of rupture. So we have to judiciously identify the patients. What is the indication of induction? It is best if the patient goes into labor on her own. If she goes into spontaneous labor, the chances of successful VBAC increases. So this is the third point. And the fourth point I would like to say, try to decrease the rate of cesarean section, because this is the one and the most important cause of uterine rupture. Primigravidas rarely rupture. The multiparous women rarely rupture if they are provided good obstetric care. It is the women with previous cesarean who rupture. So try to reduce the rate of cesarean section and avoid cesarean section on maternal request, I would say.
Can I also add that suturing is also important. I mean, the technique, the catgut used or whatever, or the double layer.
Nowadays, everyone does single layer. They don't UV fold and they just close. In our times, we were told to bury the first layer.
Bury, exactly.
Then a study came, you should not bury. There are sinuses, etc., and infection, inflammation, whatever. So basically, I think one layer is also fair enough. That's what the trial says.
Yes, Coronis trial.
I will tell you one thing. There is a culprit. There is a culprit for uterine rupture. All of you are knowing it. The residents puts that drug. They don't tell us.
Yes. Sir, I would like to share a case, similar case as you were describing. After the rupture and all that, we did a hysterectomy, and post blood transfusion, she developed big ecchymotic patches in her body and she started bleeding from everywhere. So we had to re-explore, put a drain, and then we had to put a mop inside, and after 2 days, the mop was taken out and we could save her.
Madam, you have put mops, we have put towels.
Yes.
Yeah.
But you have not answered my question. What is the culprit drug?
Misoprost.
Misoprostol.
Non-judicious use of misoprostol.
Unjudicious use of
Unindicated.
misoprostol, and this was very important, and this patient had been used misoprostol. Can you imagine 2 previous LSAS? How judiciously can you do that? You have to have that much heart to understand what is to be given, what is not to be given. You cannot expect that you press a button and the baby comes out. It takes time. Nothing is hard and fast. Unfortunately, this patient, before taking for a cesarean section, ruptured. A scar thickness evaluation is very important. At the end of the day, you cannot depend only on ultrasound. You need to have some clinical acumen. Why do you wait? So you need to have that judicious. If the baby is 2.5, 2.7 kg plus or minus 250, she's 2 previous LSCS, she's gone beyond 34 weeks, she could be PIH, anemic, etc. She's fine now, lung maturity is there. Go ahead and perform a cesarean section. Do not wait for a catastrophic event. And today's my patient, I was called from the OPD. This patient had been given misoprostol, and this was a second trimester rupture following a second trimester MTP rupture. Can you imagine? So you have to be very, very careful, not only in the 3rd trimester, but also in your MTP procedures. If you are doing before 20 weeks, and if she's previous LSCS, one scar, try to use judiciously. You do not use misoprostol. In my unit, I do not use misoprostol. I only go ahead with a Foley's catheter, installation, saline. It's a mechanical dilatation, and I'll tell you, in our time, we used to do, all of us, you have done ethacridine lactate, a miracle drug.
Yeah, Emicredil.
Yeah, extra amniotic installation. I'm just
150 ml. Yeah.
Yes, and I'm just trying to show the other picture. It's not only a 3rd trimester rupture, the incidence of 2nd trimester rupture are also happening. You need to understand that you have to go, and all of you have said rightly that have patience, go ahead and do not overuse the augmentation of labor. That's a very important. Do not try to, put some masala, this, that, pitocin, epidocin, buscopan, and then you put misoprostol and she doesn't come out. You have to have that patience. Go ahead. And I'm sure this was a lucky patient which survived, and this could have been avoided. So saving mothers' lives, well, there are pregnant women who are dying from so many causes. The most important is a pre-existing medical condition, which contributes about 28%. PIH, anemia, obesity, NCDs, severe bleeding, postpartum hemorrhage comes the next. 14% is also PIH. And then we have 11% infections, sepsis. I've seen cases with sepsis, very bad, but they have been reopened, re-explored, they've gone home. Blood clots, abortion complications, yes, 8% of them, and unfortunately obstructed labor and other direct causes. So thank you all of you for joining today. And it was
Thank you. Thank you very much.
Thank you,
Excellent
Dr.
panel. Thank you.
Dr. Komal.
Thank you all. Thank you so much.
Thank you so much.
Thank you.
Thanks, organizers.
Well, for
Dr.
involving
Avanti
us.
Madam has been my mentor, and she has been my
As
teacher and
usual.
guide during my residency in Lady Harding, and it was very nice to be to co-chair be a co-panelist along with her. Thank you so much, ma'am.
So,
You've done a good job,
Thank you, Niranjan.
Dr. Niranjan.
Before we sign off, I want to tell that we have crossed more than 460 registrations in non-COVID times, and we are doing very good. Thank you.
Thank you so much.
And a lot of positive comments from everybody. Everybody has appreciated the panel very well.
Wonderful cases.
Yes, thank you. Thank you, Dr. Alka Kuthe, Dr. Rovitas Chavan, Dr. Abbas Singh, Dr. Seema Divedi, Dr. Archana, Dr. Vijay Lakshmi Shishadri. Thank you for being the part of the panel. Dr. Anushri Rawal, thank you for being there towards the end. I think lovely discussions. Thanks to each one of you. And Pradnya is here, there. Pradnya is actually handling the near miss in Sion. And she's also also doing a great job. So I am really happy that she's waiting and hearing the discussion so attentively and so sincerely. Thank you so much. Over to you,
Pradnya
Pradnya.
is representing Sion Hospital in now the managing committee of Mumbai Obstetric Gynec Society, and she is also the secretary of the journal. Very hardworking. Thank you, Dr. Pradnya, for doing all this, getting all of us together.
Bye bye. Thank you.
Wonderful,
Bye,
wonderful.
bye.
Yeah, over to you, Pradnya, for official vote of thanks.
And
Dr.
thank you,
Niranjan
Dr.
keeps
Kanchan
active with all the
Prasad,
panelists,
a
all the
very
panelists,
dynamic
very alert.
personality, Associate Professor Dr. Kanchan Prasad. So, thank you, all of you. Thank you, Dr. Alka.
Thank you. Thank you.
Thank you.
I would like to thank the convener and co-convener, Dr. Komal ma'am and Dr. Niranjan Chavan sir, for organizing such a lovely program. It was very informative. The panel discussion went off very well. I would like to thank the moderators and the panelists and all the speakers and chairpersons for being here. And I thank the team for hosting this and all the audience for their patient listening. Thank you so much.
Thank you, Shield team. Thank you so much, Sahiti, Suman. Thank you.
Thank you, ma'am. Thank you so much. It was an honor to hear Dr. Alka Kriplani, Dr. Alka Kuthe, Dr. Niranjan sir. It's an honor for me to hear all of you. Just hearing,
Arey, kya honor, yaar.
a pleasure.
Yeah, and I
Sir,
think-
thank
I
you
think
so
we
much.
had
ऐसे
two
तो मिल नहीं
Alkas
पाते
today.
हैं. We are very, I'm in Halwani. I'm hardly ऐसे मिलना नहीं हो पाता. It's really a pleasure. That's why I did not log out. I was listening.
Very good. Thank you so much, Anushri. And I think
Thank
we
you,
have two
Komal
Alkas
ma'am.
today, Alka Kriplani and Alka Kuthe.
It was really an honor to hear both of them. Thank you, ma'am. Thank you.
Best wishes, Komal. Best wishes, Komal.
Same to you. Best wishes. Bye.